and good evening, everyone. I welcome you all for today's webinar on Current Oncology Update Series Part 6. And with immense pleasure, I would like to invite Dr. Rajat Bajaj, who is Senior Consultant Medical Oncology, Fortis Hospital, Noida, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Yeah. Good evening, everyone. Am I audible?
Yes, sir, very much.
Okay. I thank everyone for joining in this evening on this webinar, which is a two-day webinar, which is Current Oncology Update Series, where we are talking about day 1 gynecological malignancies and day 2 is lung cancer. We do understand and know that as oncologists, there is always a drive from within to talk about academics, and we also understand that always if it is we being academically driven, we'll be able to give more to our patients in our OPDs. Oncology is a field where there is always something new coming up every now and then, and this is the reason we really conduct these meetings, so that we keep abreast with what is going around, and we should be sharing knowledge so that all of us can learn together. So keeping this in mind, we have kept day 1 as gynecological malignancies, where we'll be talking about endometrial cancer, and then ovarian cancer, and then breast cancer in that order today. And to talk about this, first of all, we are going to start with the endometrial malignancies, and we are going to talk about what is new in the surgical approach to endometrial cancer. We all understand and know that surgical approach is the most important as far as the treatment and curative intent of endometrial cancer is concerned. So to take us through this topic, we have with us Dr. Desai. Dr. Desai is a surgical oncologist at Hinduja Hospital in Mumbai. Dr. Desai, good evening. Please, over to you.
Good evening. Am I audible?
Yes, you are audible.
First of all, I would thank the organizers for the kind invite. So we'll see today what are the recent development in the surgical management of early stage endometrial cancer. Endometrial cancer is one of the common gynecological malignancy. Fortunately, most of our cancers come in early stage. More than 80% of our cancers come in early stage, and surgery remains the mainstay of the treatment. The standard surgical procedure that is involved, what we do is a staging laparotomy, in which the components of the surgery involves hysterectomy and bilateral salpingo-oophorectomy, lymph nodal staging depending upon the risk factors, omentectomy in certain high-grade histologies, and peritoneal fluid cytology in all cases. Traditionally, this surgery was done through the open method. That is, open surgical incision is given in the abdomen, and these procedures are carried out. This involves removal of the uterus and the ovaries, and also the lymph nodal dissection. Depending upon the risk factors, the lymph nodal dissection involved the pelvic lymph nodal dissection as well as the para-aortic lymph nodal dissection, which is infrahilar, that is up to the level of the renal veins. But this surgery, though this is a very standard surgery, is not without any problems. This is associated with morbidity like bleeding, infections, bowel complications, post-operative pain, and one of the worst complications that no surgeon wants is a lymphedema. This is a late complication that occurs mostly because of the lymph nodal dissection. This is more so, all these complications are more if our patients are obese. Another problem that comes in an obese patient is that the technical difficulty that we face during the open surgery for lymph nodal dissection. And it is not that these obese patients are seen only in the Western countries. Even the great number of our Indian patients with endometrial cancer presents with obesity. Now, this is the era of precision surgery. What do we want? We want to decrease the morbidity associated with our surgery, improve the quality of life of our patients, but not compromising on the staging information that we are getting. We want to know the same staging information, but with less surgery, and treat these patients more precisely. So how do we do this precision surgery? One is through minimally invasive approach, which involves both laparoscopic and robotic surgery. And another thing that is for the lymph nodal staging, that is image-guided precision surgery, that is sentinel lymph node mapping. So the flow of my presentation today will involve role of minimally invasive surgery in endometrial cancer. Is it safe? Sentinel lymph node, what is it, and whether can we do it correctly, and whether it is oncologically safe, and not to forget, in early stage endometrial cancer, role of fertility preservation. So first, coming to minimally invasive surgery. As I said, minimally invasive surgery involves both laparoscopic as well as robotic surgeries. Is it oncologically safe? Traditionally, we were doing this by open methods. Minimally invasive surgery was being used since very long time, but we didn't know the safety of it. These were the two trials that were done. These are the randomized control trials that were done in early stage endometrial cancer. First one is a LAP2 study, and the second one is the LACE study, which showed that minimally invasive surgery is safe in early stage endometrial cancer. These are the results of the LAP2 study. The number of recurrences were not higher in patients who underwent laparoscopic surgery. The overall survival was also not affected in patients who underwent laparoscopic surgery as compared to patients who underwent a traditional open surgery. These were the results of the LACE study, which was published in 2017. The incidence of endometrial cancer recurrences were similar to that in open group and laparoscopic group. The incidence of death was also similar in both the groups. The primary endpoint of the study was disease-free survival at 4.5 years, which was not inferior, which was similar in both the open surgery as well as minimally invasive surgery group. So this is a summary of the data. This is LAP2 study, which was published in 2012. It was conducted in early stage endometrial cancer, where total abdominal hysterectomy and total hysterectomy and bilateral pelvic lymph node dissection was done. Dissection of para-aortic lymph node was at the discretion of the surgeons. There, the conversion rate in this trial was 26% from open surgery, minimally invasive surgery to open surgery. But this trial was conducted prior to 2012. So there were some technical difficulties that made the surgeons to convert it into open surgery. Now the conversion rates have significantly gone down, and with the evidence, more and more people using robotic surgery, it has become much lesser. LACE2 was published in 2007, where there was only 6% conversion rate, and there was no difference in for disease-free survival at 4.5 years. These are the recent ESGO, ESTRO, and ESP guidelines for the management of early stage endometrial cancers. As of now, in advanced stage or a high-risk endometrial cancers, we do not have a randomized control trial, but there is the systemic meta-analysis that was published in 2019, which comprises of more than 1,500 patients from 9 studies, which did not show any detrimental effect of minimally invasive surgery versus open surgery. So these are the recommendations that are given by ISGO and ESTRO, that minimally invasive surgery should be preferred surgical approach for patients, including the high risk endometrial cancers. But any intraperitoneal tumors village, maybe it is tumor rupture in the form of uterine perforation or morcellation, and even morcellation within the endobag to remove the specimen should be strictly avoided. If vaginal extraction of the uterus will lead to uterine ruptures. Other methods to be used like removal in the endobag or in terms of mini laparotomy. Tumor with metastasis outside the uterus and the cervix, excluding the nodal metastasis, are relative contraindications for minimally invasive surgery. The extent of surgery should be hysterectomy and bilateral salpingo-oophorectomy without vaginal cup excision. Infracoelicomentectomy should be performed in stage 1 serous carcinoma, carcinosarcoma, and undifferentiated tumors. And restaging procedures can be considered in incompletely stage high, intermediate, and high-risk endometrial patients when it is impacting our adjuvant treatment plans. Now, next coming to lymph nodal staging in endometrial cancers. Traditionally, what has been followed was that depending upon the risk factors, we were doing pelvic lymph node dissections and the para-aortic lymph nodal dissection. However, the therapeutic benefit of the lymph nodal dissections was never been proven, but it does have a prognostic value and it does guide us in planning our adjuvant treatment. It was GOG 33 trial, which was a prospective surgical study that did show that 22% of our patients, which were apparent to be stage 1 endometrial cancer, were upstage when we did a systematic pelvic and para-aortic lymph nodal dissection. So this helps in guiding our adjuvant treatment plan. But later on, Aztec and Panacea were the two trials that were conducted that didn't show any therapeutic benefits of this trial. And why do we don't want to do a systematic pelvic lymph node dissection? Is because it is also associated, increases the side effect of our surgery. It does increase our operative time. It does increase the blood loss. It causes post-operative ileus. It is really technically difficult in obese patients. And the most important complication is a lymphedema, which is a long-term complications of lymph nodal dissection. So now it's a era of precision surgery. As we said, we want to do a less amount of surgery, but get adequate information out of that surgery and decrease our complications. So what is sentinel lymph node? Sentinel lymph node is the first draining lymph node through which the cancer spread to the other lymph nodes. So here we believe that the cancer cells from the uterus will travel through the lymphatic being the most commonest mode of spread of cancer, through the lymphatics, through the first draining lymph node, and from that lymph node, it will go to the other lymph node. So if we identify the first draining lymph node of the uterus, then if that lymph node is negative, then we can consider rest of the draining lymph nodes are negative. So what we need to do is remove the single lymph node and see the status of that lymph node. And how do we do that? By injecting some dye. Like in other cancers, here we inject the dye. There are different injection sites that are available, the most commonly being the interstitial injection of dye within the cervix. This interstitial injection has shown to be good, shown to have good identification of pelvic lymph nodes, and it has low identification of para-aortic lymph nodes, but some amount of para-aortic lymph node are also identified by interstitial injection of the dye into the cervix. Now the tracers that are being used in endometrial cancer is either technetium, a blue dye, and more recently, since the introduction of robotic surgery and we having probes even in a laparoscopic and open surgery, for ICG technology, we are using ICG more in endometrial cancer. Whether we should be ultra staging the lymph nodes and doing a treatment according to that is still a controversial issue in endometrial cancer. And what we are more focusing on the diagnostic accuracy, whether we are able to correctly identify the sentinel lymph node and correctly judge whether the sentinel lymph node is representing rest of the lymph nodes or not. And of course, the oncological outcomes of sentinel lymph node biopsy. Coming to the diagnostic accuracy, film study was the first study that was published in 2018 that compared blue dye followed by plus ICG dye or ICG alone. And what did it show was that ICG is superior to blue dye in identifying the sentinel lymph node. It did identify more than one sentinel lymph node on each side of hemipelvis, and it was capable of identifying bilateral sentinel lymph nodes. ICG plus blue dye was not better than ICG alone, and the interstitial injection of ICG was a safe technique. These were the studies. That was a Centico-Indo study and the FIRES trial were for early stage endometrial cancer, and these were the two studies that were done in high-risk intermediate and high-risk endometrial cancers to see the diagnostic accuracy of sentinel lymph node biopsy. And what did it show? For the first two trials, they had a very good negative predictive value in identifying the sentinel lymph nodes, and negative predictive value of the sentinel lymph node was very high. And this was equally true in high-risk endometrial cancers too. Is it oncologically safe? As of now, we do not have randomized controlled trials to show that this is oncologically safe. Whatever data we have is from the retrospective studies, and it does shows that doing only sentinel lymph node biopsy in the patients did not affect disease-free survival as well as the overall survival. We await the results of these two trials. One is a phase 3 RCT Endo3 trial, which is started in 2021 for early stage endometrial cancers, and the SELECT trial, which is a prospective observational multicentric trial for intermediate risk endometrial cancers, which is planned to be completed in 2024. As of now, NCCN includes sentinel lymph node biopsy in treatment of staging of the endometrial cancers. What we need to follow is we need to follow the proper principle. It should be done by the trained surgeon. What is recommended is that before the start of the mapping, the suspicious lymph nodes needs to be removed. Each side of the hemipelvis needs to be mapped. If it is not possible, if any side sentinel lymph node is not identified, we should be doing a complete lymph nodal dissection on that side. What does the ISGO and ASTRO guideline state? For the low and the intermediate risk endometrial cancer, sentinel lymph node biopsy should be considered. And for high risk and intermediate risk cancer patient, it might be an acceptable alternative. Coming to fertility preservation in endometrial cancers, around 20 to 25% of our patients will be in the premenopausal age group, and 5 to 10% of our patients have not yet completed their family. These patients needs to be screened for, and we should be identifying the patients, whether these patients are fit for offering fertility preservation protocols. There are some criteria that need to be followed. It is, we give them only in well-differentiated endometrioid adenocarcinoma, the adenocarcinoma that is restricted only to the endometrium. There should be no suspicious metastatic disease outside the uterus on imaging, and there should be no contraindications for medical management or pregnancy. So what are the options that are available? The options available are oral progesterones releasing IUCDs, GnRH analogs, and hysteroscopic resection of the tumor. We do not have randomized control trials. We have only prospective studies and the retrospective data. The exact dose of oral progesterones is not known. The commonly used drugs are medroxyprogesterone acetate and megestrol acetate. The average response time that is required for high dose progesterones is minimum of 6 months, and there are chances of recurrence when we stop oral progesterones. The other options are LNG IUCD, maybe in combination with hysteroscopic resection of the tumor or in combination with GnRH analogs, and this had shown to have high response rate to the tune of 89% and a high pregnancy rate to the level of 45% pregnancy rates. What does ISCO-ESTRO guideline states? They say that hysteroscopic resection should be suggested prior to starting on the high-dose oral progesterones. LNG IUCD with GnRH analog can be an alternative. These patients does require very strict follow-up. Follow-up in terms of hysteroscopy and guided biopsy every 3 to 4 monthly, and maybe a imaging every 6 monthly. And completion surgery should be done after completion of childbearing. So to conclude, minimally invasive surgery should be the standard of care in endometrial cancers. Sentinel lymph node biopsy should be considered in low and low intermediate risk endometrial cancers. And we should be aiming at the treatment with minimal morbidity, and the adequate staging should be done with minimal morbidity. Thank you.
Thanks for a very informative talk. I think you very clearly talked about all the points and covered all the points which are important for the medical cancer. I have one of the questions to ask you. In this era of robotic surgery and speaking of robotic surgeon is how do you really treat your patients, or rather, if I have to put it this way, that are there any subset of patients whom you would not take up for an minimally invasive surgery or for a robotic surgery and rather go for an open surgery? So, what are the points that will take you in favor of an open surgery and not a robotic surgery?
As of now, I'm doing offering minimally invasive surgery only to the patients who are low risk, not high risk, not a type 2 histologists. We are not offering the minimally invasive, though it is shown to be safe, but I'm not comfortable. Another thing, if the uterine size is very big, or there are chances that we might not be able to remove the uterus without morcellating it, or without, there is a chance of uterine rupture. Those cases we are not offering minimally invasive surgery. Otherwise, most of the cases we are offering minimally invasive surgery.
Okay, anything to do with the BMI as well?
Pardon?
Because in lab 2, anything to do with the body mass index as well, because in the lab 2 surgery,
robotic surgery, we subject more, if the body mass index is more, we subject them for the robotic surgery. If it is less, like extremely thin patient, we subject them for, we don't offer them robotic because it becomes too costly, and it can be very easily done by laparoscopic approach. But most of the patient, almost every patient gets the option of doing it by minimally invasive surgery, either robotic or laparoscopically.
So the reason why I'm asking that is because in the lab 2 surgery, the most number of patients who were converted from MIS to open were, most of them, they were obese patients. So
yes, that problem is solved basically in robotic surgery. That problem doesn't come because you are less dependent. We do have conversion rates. That might be because technical problems, or we want to do a para-aortic, sometimes becomes technically difficult if we are not using sentinel lymph node. Now, more and more patients are undergoing a sentinel lymph node biopsy. So removing a single lymph node does not become a problem, but doing a systematic para-aortic lymph node dissection in a morbidly obese patients become really technically challenging.
Okay, and the last question is that there are few papers to suggest that there is some minimum number of lymph nodes that need to be removed in the para-aortic domain is what I'm talking about. So what is your take on it? Do you really follow any minimum number of lymph nodes removal in para-aortic dissection?
So para-aortic area, when we do dissect the para-aortic lymph node dissection, we do a complete lymph nodal dissection infrahilar. The minimum at least that we should be getting is 8 to 12 lymph nodes. So if your pathologists are good and they are ready to dissect all the lymph nodes, they do dissect the lymph nodes. But coming to looking at all the studies that are being conducted, it does not have a therapeutic benefit. But if the lymph node is enlarged, definitely we need to remove all the enlarged lymph nodes. That is required for the adequate staging, and we don't know whether leaving behind the positive lymph node will have whether it will have a negative impact on the disease recurrence.
Right. Thank you so much for a very nice presentation, David. So
Thank you.
we move ahead now, and after talking about the surgical approach, we talk about what to do once the surgery has been done. That is the adjuvant treatment. A good surgery always should be followed by a proper adjuvant treatment, and we do understand that there have been developments in the adjuvant treatment protocol of endometrial cancer as well. And to talk about this, we have with us Dr. Kripa Bajaj. She is a consultant medical oncologist at Indo-American Hospital and Research Institute, Hyderabad. Dr. Kripa, good evening. Please take it forward.
Good evening, Dr. Rajat. Thanks for the opportunity. It's a great opportunity to discuss endometrial cancer. A lot of confusion is there whenever we conduct tumor board in endometrial cancer adjuvant management. So what's new in adjuvant treatment of endometrial cancer? There is classically two types of endometrial cancer, as all of us know, type 1, type 2. Type 1 is an endometrioid histology, low to moderate grade and well differentiated, whereas type 2, it is high grade, poorly differentiated one. Type 2 is always having a unfavorable prognosis, usually non-obese females. So as Dr. Sampada rightly covered, surgery is always the mainstay of treatment, the TAH base of without or with vaginal cuff resection. So depending on the stage, sometimes people do deviate either ways. And surgical-pathological FIGO staging is a mandatory. Based on that, everything will change. Detailed histopathology is a mandatory and should be recorded. The histological type, FIGO grade, biometal invasion, LVSI. LVSI focal versus substantial is a very important. Why it is so important, I'll discuss later. Lymphadenectomy role, not so well defined. It's a lot of confusion is there, as Dr. Sampada rightly told. And some people who are not eligible for surgery, they are high risk to get surgery. Sometimes radiotherapy alone also is a beneficial as a palliative setting with reasonable decent outcomes. So sentinel node biopsy, I'm not going to touch upon because she discussed quite extensively. But intermediate risk, high intermediate risk, some research areas are going on. There is no strong evidence for that. Lot of evolution happened from 2016-17 when I started DM. By the end, everything got changed. By the time I entered practice, lot of things got changed. Endometal carcinoma is a very dynamic subject. I believe in the management of gynecological malignancies. So the recent 2021 September, there is a ESGO Astro SP guidelines are there. Lot of things got added in there. In this guidelines. So this is the main crux of the discussion today for us. So it's extensively discussed in any panels that the TCGA classification of endometrial cancer, the 4 types are there from the 2013. What are the clinical implications of this TCGA classification? So if you see, the different types of classes have a different outcome. The PFS is quite different. If you see, the poorly ultra mutated is having a favorable prognosis compared to other copy number high, that's a so-called serous one. So substantial difference in the outcome got noted by molecular classification differentiation. So if you see the non-endometrioid, it's just not endometrioid confined one, even the non-endometrioid, the high-risk endometrial carcinomas, clear cell, undifferentiated or dedifferentiated, the polymutated have a very good prognosis. So soon in future, gone to be the histological type, grades and everything. It will be pole mutated, P53 mutated, NSCP mutated. Mostly this will be the discussion. So when to do, where to do, what are the clinical implications is a further discussion. So be it any histology, these mutations decide the outcome of the patient. It's not just the histology grade alone. So it's going to evolve so well. So the PORTEC one, it's all retrospective analysis. Whatever got published, the molecular analysis, it's a retrospective analysis. PORTEC 1, PORTEC 2 cohort, the first cohort which got analyzed, there's substantial difference in the outcome got noted. So later, the JCO publication 2020, this is a landmark paper, I believe, in the management of endometrial cancer. Everyone argued that it's a retrospective analysis. We can't take forward with this retrospective analysis regarding the adjuvant management. If you see, the curves are so stark. The PORTEC 3, all of us know it's a RT versus CTRT. If you see the outcomes in a molecular classification wise, P53 substantial improvement is there. The prior so-called endometrioid grade 1 with P53 mutation is having a stark difference in the outcome based on the CTRT. So if you see, this is the high risk endometrial cancer, the retrospective analysis of the PORTEC 3 study. The PORTEC 3 study, the inclusion criteria, why it got analyzed, why it got so much of prominence, I'll discuss during discussing the PORTEC 3 study. To brief you, PORTEC 3 study retrospective analysis of JCO 2020 paper. there is a difference in the outcome by CTRT versus RT, P53 abnormal versus normal one. Polymutated, NSMP, MMRD, they have a difference, but P53 strong difference is there. So how we are going to do the molecular classification? The recent one, like which the ESCO suggested to do the molecular classification, how to do? Poly status, to my knowledge, everywhere in India, though they are giving reports, it is just getting standardized. In TMH, it got standardized very recently. So polymutation is done by DNA sequencing. MMR status as well as P53, we should do by IHC. It's fine to do by IHC because the sensitivity specificity is like equally good. So polymutated tumor, already mentioned, excellent prognosis will be there. MMR deficient, NSMP deficient, intermediate prognosis. P53 abnormal, it's a poor prognosis. So this is a schema, like how should we go about the flow chart of testing? First, if ever new sample is there, do the MMR IHC. If it's intact, then go for the poly. If it is again wild type, then to go for 53. So MMR, poly, P53. This is a sequence and schema of testing on this tissue. I'm sorry, excuse me. This is a 2020, again 2021 also this published this. I'm sorry. What is the real difference 2016-17 versus 2021 guidelines of ESCO-ESTRO-SP? You see the high risk, stage 2 is in the high risk. Before, now later it was converted in 2021 into high intermediate risk. It's no more high risk. And again, what's new, really new compared to the old classification is stage 1A non-endometrioid histology without myometrial invasion is a new entity with the intermediate prognosis. It's no more to be included in the high risk. In high risk, only entity with the myometrial invasion is included. So, P53 carcinomas restricted to the polyp without myometrial invasion, adjuvant therapy is clearly not recommended, though it's a level 3 recommendation not to give, but there is no evidence to give adjuvant therapy. So this is the, again, I'm discussing the poly should be done in stage 1, stage 2 only. Stage 3, stage 4 and further, there is no evidence to do the poly mutations. It's always MMRD, NSMP, P53. This, you keep this in mind, like for the further discussion. All the adjuvant treatment trials, this is the practice defining trial. We know our radiotherapy colleagues are like so important in the management of adjuvant treatment of endometrial cancer. The first trial to disclose the benefit of radiation is the Aztec trial. So all these trials, like for us, pertaining to us, it is POTEC 3 and GOG 258 is a very important trial to us. The rest are the radiotherapy trials. So coming to the risk category, the low risk category, it's a stage 1A endometrioid low grade type without any LVSI or focal LVSI. Mind it, stage 1, stage 2 polymutated endometrial carcinoma is a low risk carcinoma. So there is no adjuvant therapy is required in this group. Whereas intermediate group, unknown as well as known, 1B, 1B low grade, 1A high grade, are the confined to the polyp. The first, the two classes, adjuvant brachytherapy is suggested, and omission of brachytherapy is suggested for the young population. Whereas with the polyp confined, there is no advantage of giving the adjuvant therapy. Coming to the high risk, substantial LVSA stage 1 or 1B high grade or stage 2, there is a difference like in the management. Stage 2, EBRT suggested, whereas in the stage 1 extensive LVSI, if the pelvic lymph node dissection was done, only brachytherapy suggested. If pelvic lymph node dissection is not done, will not be attempted because of the post-morbidity, then EBRT has to be given. So this is a very distinct one. So LVSA positive, no dissection was done, EBRT. If dissection was done and again the loads remain zero, it is only vaginal brachytherapy. And again, 1B high grade, you have to go for a EBRT. Whereas a high risk, without any doubt, you have to go for the concurrent CTRT or sequential CTRT based on the institute policy. So carcinosarcoma should be treated as a high risk carcinoma, not as sarcomas. To the point, like I'm mentioning, all the undifferentiated serous carcinosarcomas, like with myometrial invasion, we have to treat like a high risk. For the rare patients with endometrial carcinoma, stage 3, stage 4, and pathogenic polymutation, there is no outcome data with the omission of adjuvant therapy. So as of now, only stage 1, stage 2, we are doing poly. 3, 4 should not do, because if poly is mutated in the 3, 4, we have no evidence like to omit the adjuvant therapy. So this is the crux. So this is the schema like of the management. When advanced disease got noted, we have to do the surgical debulking as much as possible, and later we can consult with chemo, or either way. If surgery is not possible in the first setting, delayed surgery is also fine. So that's how you do the advanced disease, which is like going to have a residual disease. So surgical debulking, it's always important. So all the time, that's why we give some chemotherapy, we will debulk the tumor, and later we perform the surgery, so that patient will have a better PFS. So this is the management, the adjuvant management differentially to the each stage, each risk group I mentioned. So now, what are the 2 important trials pertaining to the CTRT for the medical oncologists? These are the 2 trials, PORTEC-3 and GOG 258. So what is PORTEC-3? PORTEC-3 RT versus CTRT. PORTEC-3 RT versus CTRT. GOG 258 is chemotherapy versus CTRT. So what is the inclusion criteria? It's quite different. PORTEC-3 inclusion criteria and GOG 258 inclusion criteria is quite different. In PORTEC-3, if you see, the high intermediate risk, all the one got included. The stage 1A grade 3 and stage 1B grade 3, stage 2, stage 3, stage 3C. So all these got included, and also all stage 1 like clear cell histology also got included. So this is a very vast groups of patients got included in the PORTEC-3. So that's why there is a evidence, like we got an evidence that if a stage 1 p53 positivity is there, the patients will have a benefit with the CTRT. So this is distinguished groups of patients got included in this one. That's why the robust outcome of p53 got noted because of this distinguished population inclusion. So this is a study design. The high risk endometrial carcinoma, whatever I mentioned, like clear cell, like stage 1 high grade, everything got included. So in this one, CTRT versus RT got randomized, and later sequential they gave a chemotherapy 4 cycles, as all of us know. The 4 cycles was given post completion of CTRT. So this is the schema of the study design. So the majority, like almost like 50% are the stage 3 patients. Rest 1A, 1B, 2 got included. The rest of 40% of the patients. So what are the outcomes? In general, PORTEC-3, the overall survival, there is a benefit of chemotherapy over RT alone. It's a failure-free survival is 7%, OS is 5%. Coming to the group analysis, for stage 3, there is significant benefit of OS by 10% and failure-free survival by 12% at 5 years analysis. If it is serous histology, the outcome with the chemotherapy is significant. The overall survival improvement is 18%, which is unheard in any malignancy. So as of now, like what is the conclusion of PORTEC-3? With CTRT, there is a good benefit in stage 3 and also substantial benefit in the serous histology. So that is there. The serous histology, then it was only just the histology with stage 1B and all. But now we are all aware that already discussed, p53 positivity patients will do behave like a serous histology patients. So that is the outcome. So serous histology, they want to give irrespective of the stage. Stage 3 endometrioid, everyone they have to give by the date of PORTEC-3. So GOG 258, this is a very different inclusion criteria, different trial altogether. In this one, stage 1, stage 2 endometrial clear cell as well as serous histology got included along with stage 3, stage 4. It's a predominant stage 3, stage 4A with small amount of clear cell as well as serous stage 1, stage 2. And this got randomized to chemotherapy only 6 cycles versus CTRT. They want to test whether really RT is going to beneficial or chemotherapy is working more than other. So again, as I told you, it's a 50%, more than 50% is a stage 3. Predominantly it is stage 3. This is stage 1, stage 2 includes a very small amount. It's 2.7% like that. But if you see the PORTEC-3, there is a robust inclusion of stage 1 patients who are having high risk. So what is the outcome of this one? Chemotherapy versus CTRT, absolutely there is no difference in the outcome. If you see the RFS as well as OS, absolutely curves are bang on. The relapse-free survival is like almost like equal. There is no difference in the chemotherapy alone versus CTRT, questioning the benefit of radiation. But when you do the sub-analysis, though the recurrence-free survival is looking like promising with the chemotherapy alone, omitting the RT morbidity, if you see the vaginal recurrences, pelvic recurrences are significantly high in the group who received the chemotherapy alone. Means the local recurrences are high in patients who received chemotherapy alone. Contrary to this, patients who received CTRT, they have a distant recurrences compared to patient who received more chemotherapy. So distant recurrences can't be, pelvic recurrences can be salvaged, but distant recurrences can't be salvaged. But still, GOG 258 was not taken across the community. So now everyone is like almost following like to give CTRT sequentially or concurrently. So stage 3 comparison, cross-trial comparison, POTEC 3 versus GOG. So if you see the stage 3 outcome, almost like 10%, more than 10% difference is there in the two groups. Maybe the spectrum of stage 3 is like different in the both trials. But the benefit, though the benefit is different, the comparison was like very apt. To see this one, the inclusion criteria, I just want to mention like stage 3, stage 4, any histology, very small amount of like clear cell serous. In this one, there is a robust evidence, like robust inclusion criteria and with a very good population. So if you see the comparison, I already mentioned systemic relapses versus like local relapses. So POTEC 3 versus GOG 258, like there is a CTRT people are having a very low local relapses. Systemic relapses are comparable. So it's not so starkly different, but local relapses are starkly different. So that's why we are adapting the CTRT for chemotherapy or sandwiching technique based on the institution policy. Does the sequence matter? So different institutions follow different way. The current institute where I'm working, they do practice sandwich technique. The institute where I got trained, they used to give first chemotherapy followed by radiation because the compliance is quite low if give chemotherapy after radiation. That's why we used to give like 4 cycles before the radiation, in the adjuvant part. But does the sequence really matter? No. There is no difference in the outcome of a person. Like this is a multi-institution analysis of adjuvant chemotherapy and radiation sequence. There is no difference in the outcome, irrespective of like any therapy, be it a sandwich, be it upfront RT, be it upfront chemo. There is no difference in the outcome at all. So it's comfort of a clinician and institution. So, and again, this is a phase 3 trial, adjuvant pelvic radiation with a EBRT versus vaginal brachytherapy plus paclitaxel in a patient with high intermediate risk and high risk early stage endometrial cancer, predominantly serous histology. In predominantly serous histology, we expect chemotherapy to do more wonders and we can down titrate the vaginal brachytherapy. But here, surprisingly, EBRT worked well in serous histology. So in serous histology, by giving more chemotherapy, omitting EBRT is not a wise option. So that we have to keep in mind. Next, this is the conclusion slide. Stage 3, stage 4A, irrespective of the histology, we have to give adjuvant chemotherapy and like CTRT and adjuvant chemotherapy. If serous histology are P53 mutated, stage 1A with myometrial invasion, stage 1B, stage 2, we have to give adjuvant chemotherapy and radiation. Presently, CTRT and 4 cycles of paclitaxel is a standard. Look at patient factors also. That's a performance status, comorbidities. Adjunct RT can be omitted in some patients. Yes, I think like patients who are having a ovarian metastasis, in those patients like the stage 3 technically, who are having a serous, they do behave more like a ovarian cancer. So in those cases, maybe I'll be pro to give 6 cycles of chemotherapy than giving radiation. So serous histology, stage 3, I will be pro to follow the GOG 258 protocol, but not the CTRT and 4 cycles of chemotherapy. The future for adjuvant therapy of stage 1, lot of confusion, discussion always there, will be resolved by the introduction of molecular features of the endometrial carcinoma, whether to observe or whether to give radiation in very favorable classifiers like polymutated patients or MMR deficient patients. Maybe the role of immunotherapy also will come into play in future. So a lot of things are happening. The POTEC 4A will answer the early stage endometrial cancer management. So the role of PARP inhibitors, checkpoint inhibitors, targeting HER2 is yet to come. As of now, HER2 is only in the metastatic setting. Adjuvant we are not using. Maybe in future it will be seeing the dawn. So utility in preoperative risk stratification to tailor diagnosis surgical management is always a crux, the basic crux to manage endometrial cancer. So it needs a prospective validation on larger cohorts with clinical outcomes. So most of the times when we discuss in tumor board, people do differ if I say P53 because it's retrospective. So if there is a robust evidence with the larger cohorts, it will become a level 1 evidence for wider dissemination and implementation in routine clinical practice. The summary: Low risk, intermediate risk, high risk. Low risk, that's a polymutated stage 1, stage 2. MR deficient NSMP stage 1, a low grade. There is no adjuvant treatment at all. Only Dr. Sampada Desai is required to do surgery. For intermediate risk, then comes the vaginal brachytherapy picture. Intermediate risk, vaginal brachytherapy will play a role. High intermediate risk, pelvic radiation, as I told you, depending on the pelvic lymph node dissection done or not, brachytherapy versus EBRT has to be introduced. For stage 2, definitely you have to give EBRT. But still high intermediate risk, CTRT will be given, but not a adjuvant chemotherapy. Just EBRT will be given. Some people do give cisplatin also in young population, but till high intermediate, only radiation or not is a question. So surgery, vaginal brachytherapy, pelvic radiation. This is the schema. Coming to the high risk, you have to give radiotherapy as well as chemotherapy combined. So how many cycles, how to give, patient to patient, it will differ a lot. And advanced metastatic setting, so Dr. Advait Gore will discuss regarding this one, how to manage advanced metastatic endometrial cancer. It requires multimodality treatment again. I thank Dr. Rajat Bachad for giving this opportunity.
Thank you, Dr. Kripa Bajaj, for this very nice presentation and elucidating in front of us a very difficult topic, I should say, because adjuvant treatment is not easy. There are a few interesting points that I could see. You said that in stage 3, you are not in favor of adding radiation, is what I understood. So,
Serous histology, definitely, because it's not uncommon for us to see serous histology with ovarian deposits. We'll have a very small myometrial invasion, but we'll have a significant ovarian deposits. So in that conditions like serous, I do push more chemotherapy because the biology will behave like ovarian cancer most of the time, serous 53 mutation positive. So I would like to give 6 cycles of chemotherapy than giving CTRT and all. Only in some subpopulation, definitely I try to give more chemotherapy.
what about endometrioid histology stage 3? Radiation is on?
Yes, it's on.
Okay. So it is more of Portec 3 and not GOG 258.
Yes, sir.
And if you're talking about stage 2, so stage 2 grade 3. So if you have a stage 2 grade 3, what do you recommend? Would you recommend chemotherapy?
No. It's only EBRT, sir. As of now, it's only EBRT. Prior, the high risk, like we used to give like the CTRT and sequential chemotherapy. But the current guidelines, there is no role of like giving the chemotherapy in stage 2. It's only EBRT. Even there is a evidence that in stage 2, grade 1, without any LBSA, we can just do brachytherapy and omit EBRT also.
Yes, again, is that how do you really incorporate the clinical trials and the TCG analysis?
So as I all
there is a there are many a times one tends to think that if you're talking about Portec 3, we are following Portec 3. Suppose it is a 1B grade 3, which comes into the purview of Portec 3, and then we also come to know that it is Pol E mutated. So how do you take that?
So to be honest, polymutation is expensive. It's 30,000 thing. So I haven't used in many patients. Maybe 1 or 2 I used it. But 53 IHC as well as MMR IHC is very easy to use. It's just like $3,000 to get it done. So as of now, I'm doing IHC for MMR P53. Only selected patients who are really affordable. Then I'm sending for poly because poly we know it is getting standardized in many labs. Though they give the report, we are not sure whether it is a real DNA sequencing with a decent report. So if it is a stage 1, stage 2 with the P53 mutation positive, as I mentioned, like P53 IHC positive, then I do take up for CTRT and sequential chemotherapy, vice versa. If it is MMR deficient, then I do think like, definitely it is not high risk. So then I would go for the traditional pathway as I showed before. Polymutated stage 1, stage 2 really is going to break path breaking because it's a low risk, no need of therapy at all for that.
Yes. So I think poly is very important in the cog in the wheel in the deciding the management of adjuvant endometrial cancer in times to come, now with the coming in of POTEC 4A also and its results. And of course, as you very correctly mentioned, that standardization is required, and also if the cost can be brought down, then more and more number of patients will be able to avail the facility and probably do away only with surgery and not get the effects of chemo or radiation if they're not required. Right. Thank you so much for this very nice presentation.
Thank you,
So,
sir, for inviting me for this discussion.
thank you. So now we move ahead from surgery to adjuvant treatment. But as oncologists, we also know that many of our patients, maybe if I can term it as more than 50% of our patients, after the adjuvant treatment do turn around to become metastatic, or we have to give them therapy for advanced endometrial cancer. To discuss about what are the new treatment options for advanced and metastatic endometrial cancer, we have with us Dr. Advait Gore, who is Associate Director, Department of Medical Oncology at Nanawati Cancer Institute in Mumbai. Dr. Gore, good evening.
Hi, good evening, Rajat. Thank you for having us here, and thank you from the organizers. So over next 15 minutes, I would touch upon what newer treatment options for advanced and metastatic endometrial cancer are. And we've just heard a wonderful talk from Dr. Kripa Bajaj mentioning about how surgery, in which situations now we are looking at offering only vaginal brachytherapy versus EBRT versus CBRT. And in looking at the stage 4A, 4B disease, surgery, yes, definitely has a role. Radiation, hormone therapy in endometrioid histology, combination chemotherapy, and also targeted treatment and immunotherapy are coming into the picture. The GOG 209 essentially looked at cementing the position of paclitaxel and carboplatin as a combination for advanced endometrial cancer as compared to the 3-drug regimen. It did show that it was comparable, and hence it got established as a standard of care. However, a lot of things have changed since the advent of chemotherapy and the entry of molecular testing for making informed decisions in endometrial cancer. And nowadays, we are doing MMR testing by IHC to test for MLH1, MSH2, MSH6, and PMS2. We are also looking at HER2 status. And there are other mutations like the POL-E and the TP53, which were spoken about. Dr. Kripa also spoke about the TCGA molecular classification and how the outcomes differ with patients with POL-E, a mutant showing a very good response. So currently, what we would do is to test for the MLH1 promoter methylation status, that is what is recommended, and to look for deficient MMR testing by IHC to look for the protein loss. Now, coming to immunotherapy first, we have the Keynote 158 update. This has shown this drug has been approved by the FDA into May 2017, and this was based on biomarker regardless of the tumor type. And the Keynote 158 was the prospective open-label phase 2 study in patients having MSI high or deficient MMR solid tumors. And we see in terms of endometrial cancers, they had 99 patients with advanced endometrial cancer and an overall response rate of about 48%, almost 14% patients in CR, 34% showing PR, and a median progression-free survival of about 13 months with a median duration of response and overall survival not reached till the time that this went into publication in the JCO in 2022. The same publication then showed that the waterfall plot showing that there was a significant change from the baseline in the target lesions. The duration of response is also maintained for majority of the patients for up to 2 years, and some of them have even ongoing response. I see in the graph that almost one third or 1/4 patients do have an ongoing response, and the median duration of response has not been reached with almost 49 months plus of a duration that was seen. The blockbuster drug for ASCO, dostarlimab, in deficient MMR endometrial cancer. This was a phase 1 study, median follow-up time of 13.8 months. This drug got accelerated approval in April 2021 for patients with deficient MMR, recurrent or advanced endometrial cancers. And we are seeing again an objective response rate of almost 46% with a disease control rate of 55%. There is an ongoing trial which is evaluating this dostarlimab in combination with chemo, but these were the response outcomes across cohorts. The overall response rate, 43.4% in patients with deficient MMR, 38.7% in the deficient MMR non-EC group, and the proficient MMR group showed a response of only 13%. There has been an update which was published in Cancer, Chemotherapy and Pharmacology. This was an update from the phase 1 Garnet study of the cohort 1A and 2, and cohort 1A1 was the deficient MMR MSI high, cohort A2 was the proficient MMR or MSS. And both these looked at about 150 and 160 patients. Dostarlimab was given 500 milligram 3 weekly for 4 cycles, then 1000 milligram IV every 6 weekly until progressive disease. And this was presented at ASCO 2022 as an abstract. Again, we see overall response rate of 45% in the deficient MMR population versus 15% in the proficient population, CR rates of 16%, partial responses in almost 30% of patients, and we see a disease control rate of close to 60% in patients who are having deficient MMR. These were the probabilities of progression-free survival in the deficient MMR cohort A1, which pegs the probability of PFS at 24 months to almost 40%, as compared to proficient MMR, where it is the 24-month probability is only 9%. This is also the overall survival, 60% versus 38% at 2 years. And the single agent immunotherapies, both of these, Pembro as well as dostarlimab, do show that they are quite safe to be given. There are some immune-related adverse events, mainly hypothyroidism, hyperthyroidism, pneumonitis, and colitis, which were seen, and most of these adverse events are low grade. In terms of immunotherapy combinations, we have the Keynote 775 or the study 309, looking at lenvatinib plus Pembro in patients who have progressed after platinum-based chemotherapy. These patients had to be of good performance status. 827 patients randomized 1:1 to either Lenva Pembro versus physician's choice of treatment, receiving either doxorubicin 3 weekly or paclitaxel 3 weeks on, 1 week off schedule. On basis of this, there was a full approval in September 2019, and FDA again gave a full approval after this data set was released in July 2021. This was a landmark paper in the New England Journal this year, which also shows that a median duration of response in patients who were in the overall population, lenvatinib plus Pembro, 14 months of median duration of response as compared to 5.7 months. Overall response rate of about 30% versus 14%. And this is in terms of all comers and proficient MMR. We see here in terms of PFS and OS, the combination has a median PFS of 6.6 versus 3.8 in the proficient MMR population. If you look at all comers, slightly better, 7.2 versus 3.8. And in terms of overall survival, 17 months of overall survival with the combination as compared to chemotherapy. This was a post hoc analysis, which was an abstract presentation at ESMO. And this looks at endometrioid serous and clear cell histology. And irrespective of the histology, the combination of Len plus Pembro does show that there is an improvement in the median PFS. In terms of overall survival, there is no statistically significant difference, though the numerical values are better. Treatment-related adverse events, we all know that lenvatinib is a difficult drug to tolerate. Hypertension, hypothyroidism, diarrhea are common. Bleeding tendencies are also common with lenvatinib. An interesting concept of EndoBar study, which looks at atezo-bev plus rucaparib. So this is combining a targeted therapy with immunotherapy and PARP inhibitor. Patients who had recurrent epithelial ovarian endometrial carcinoma with 1 to 2 previous lines of therapy Some patients were allowed anti-angiogenic therapy except for bevacizumab, and these all patients were not allowed any prior immunotherapy. Small study, 30 patients, endpoint of overall response rate. We see here that 42% overall response rate, one patient each with a CR in MSS and the MMR deficient subgroup. No patients with deficient MMR achieved less than a partial response. Duration of response, the median duration of response is around 6 months for the microsatellite stable population, about 4 months for the MMR deficient, close to 10 months. EFS and OS curves are limited because this is a shorter study, median overall survival of 15 months, median event-free survival of about 6 months. In terms of safety summary, we look at more than grade 3 adverse events. Acidosis, hypotension were common, but treatment-related adverse events which required discontinuation was only seen in about 9% of patients who were microsatellite stable. What is new in targeted therapy? Selinexor, which is a SINE inhibitor. We were part of this study for myeloma. This has also been evaluated in recurrent endometrial cancer in the CINIDO study, which is a phase 3 study, stage 4 or first relapse of endometrial cancer irrespective of histology, who had a partial response or a complete response on more than 12 weeks of first-line treatment with the taxane platinum, 2:1 randomization to selinexor 80 milligram given once a week, and versus placebo. Of course, these were continued till progressive disease. This was an investigator-assessed PFS, median PFS of 5.7 months for the selinexor versus 3.8 for the placebo at a median follow-up of 10.2 months. By the histological subtype, we see here the difference between endometrioid and serous histology. Serous histology, there is not much of a change, but in endometrioid, median PFS is 9.2 versus 3.8. When we look at wild-type P53 endometrioid carcinoma, 13.7 months of PFS as compared to 3 months in patients on placebo. There wasn't really much difference in the quality of life as per the QLQ-C30 scoring, and there was patients did tolerate this well. There were some symptoms in terms of diarrhea, nausea, vomiting, although the patients on selinexor did require, almost 50% of them did require some dose reduction or dose interruption in between. This was the preliminary subgroup analysis, which was presented at ASCO 2022 this year as an update. And this shows a predefined exploratory endpoint based on the histological subtype, including the molecular subclassification, including the P53 MMR and the POL E. So this is in terms of the mutant or aberrant P53 endometrioid carcinoma, where we see that it really doesn't work that much. This is in terms of the POLE, MSI high, and the copy number low or copy number high. And we see that patients who were having copy number low, they are doing much better as compared to other populations. Looking at HER2 overexpression, we've seen that about 20 to 25% of patients do express HER2 or a FISH positivity, and trastuzumab with paclitaxel and carboplatin is one of the recommended treatments as per the NCCN for recurrent HER2 positive endometrial cancer. Testing is an issue because there can be significant intratumor heterogeneity, and almost 5% to 50% intratumor staining intensity can change. In terms of parameter or cutoff, for endometrial serous carcinoma, more than 30% positivity is what is taken as IHC3+, and in terms of FISH, a HER2 by CEP17 ratio of more than equal to 2 is what is considered as positive. And the phase 2 trial in 2020 did show that the combination of paclicarbo plus trastuzumab shows an updated survival analysis at a median follow-up of 25 months, shows that there is a median PFS is about 17.7 months for the combination versus 9 months for the chemotherapy alone. There are multiple ongoing phase 3 trials of immunotherapy in recurrent advanced situation. There is a RUBY or NGOT EN6 study looking at dostarlimab plus paclicarbo, followed by a placebo or dostarlimab, or the third arm of niraparib plus dostarlimab. which we are awaiting results. Another interesting study is the EN9, which is currently stopped recruiting patients, which is looking at lenvatinib plus pembro versus paclitaxel as first line and second line therapy in advanced endometrial cancer with PFS and OS as primary endpoints. So current guideline recommendation for relapsed or recurrent disease in terms of local recurrence, the option still remains surgery and radiotherapy. We all know that local regional recurrence is rare, so the consideration on removing the isolated or local recurrence should be looked at. In terms of local therapy, external beam radiation plus minus chemo with brachy may be preferred in certain situations. Systemic treatment can be considered either before or after radiotherapy. In oligometastatic disease, a radical local therapy approach is used. Radiation also used as palliative treatments to reduce bleeding or pain from pelvic disease or from distant metastasis. We have multiple systemic therapy options for recurrent disease now. Hormone therapy agents, which were used for many, many years, still do remain a part of the treatment plan. Systemic treatments have evolved from platinum treatment rechallenge to looking at doxorubicin and paclitaxel, which does still remain the most active drug. And an anti-PD-L1 monoclonal antibody like pembro in MSI high or deficient MMR or dostarlimab in deficient MMR tumors are the options for looking at single agent or combination of lenvatinib plus pembro, regardless of histology, even in MS stable or proficient MMR tumors is what one would look at today. I thank you all for a patient hearing. Thank you.
Thank you, Dr. Gore, for this very nice and informative talk about the management of advanced or endometrial cancer. I have one or two questions to ask you. Do you start with the taxane and platinum in your practice in recurrent endometrial cancer, or do you also resort to the triplet combination of paclitaxel, carboplatin, and doxorubicin, which was tried in one of the GOG trials? That is number one.
Yeah, so I prefer to use the platinum carboplatin, platinum plus taxane doublet because the tolerance is much better. Most of the patients who've had recurrent disease either have had a stage 3 or a stage 4 disease where they've received full CTRT, and then looking at incorporating an anthracycline during the treatment protocol becomes difficult.
Okay, and what is your go-to drug for second line if we're talking about chemotherapy? Is it doxorubicin, or are you resorting to topoisomerase inhibitors in your practice?
I generally prefer topoisomerase. Anthracyclines, if at all, comes later on if the patient does not tolerate the topoisomerase inhibitor, or if we are looking at even gemcitabine in certain situations when our back is against the wall and the patient can't go for any of the immunotherapy options.
Yeah, so very important point there, because most of the times we do understand that there is good data about doxorubicin, be it in endometrial cancer or for that matter in breast as well. If you're talking about a metastatic breast post single agent taxane, but then we are not able to offer that to our patients because of not a very good or a preserved performance status. Very, very rightly said. And the other thing is that are you resorting to a comprehensive next generation sequencing in your patients to find out any targeted therapies out of the basket trial of NTRK or PIK3 in your practice?
Yeah, so in select patients we do offer them. Patients especially who go beyond the first or second line of therapy or even first line recurrence, for those who can afford it. Yes, we are asking a broad molecular NGS pattern to look for other actionable mutations because we have limited options in terms of managing these patients. Many of the patients do still remain quite fit even after second line of therapy. I would say that about 30 to 40% patients still remain fit enough to receive a third line treatment in endometrial cancers. And that is where this information does come in handy.
Right. Thank you so much for being a part of this webinar. Please stay with us. Thank you for this informative talk. So after this talk by Dr. Gore, we go on to the next topic of the webinar, which is on ovarian cancer now. from endometrial to ovarian cancer. We're talking about survival in years. Can we cure ovarian cancer? And this is a pharma-sponsored session by AstraZeneca, where we're going to talk about the role of PARP inhibitors in ovarian cancer. And to talk about this, we have with us Dr. Denny Gupta. Hi, sir. Good evening.
Hi, good evening,
Who is
Rajat.
a senior consultant in the Department of Medical Oncology at Dharamshila Narayana Super Speciality Hospital, Delhi. Sir, over to you.
So good evening, everyone. I hope my slides are visible.
Yes, sir, they are. Yes.
Yeah. So just a moment. So at the outset, I would like to thank Astra people and Dr. Rajat for inviting me here. So today's topic, which I was supposed to talk, is survival in years. Can we cure ovarian cancer? So all of us know that we are treating ovarian cancer. A lot of patients are coming even beyond 5 years, which we are treating with some sort of chemotherapy or immunotherapy or targeted drug. So many a time, every year we switch on to some chemotherapy or something other. So with the light of recent data which is emerging with the PARP inhibitor and other VEGF inhibitors. So today's CME is focused particularly what are the options with which we can increase the survival of ovarian cancer patients. So main highlighting point over here is about PARP inhibitor. But apart from PARP inhibitor, which other points which I am going to speak on a little bit. First is choosing the right candidate for neoadjuvant chemotherapy. What is the current exact scenario, and either whether there is a role of HIPEC in some of the patients. Third is extending the anti-VEGF therapy. Is there likelihood to improve outcomes? Targeting PARP, because there are two abstracts were presented in recent ESMO regarding olaparib in this scenario. And last is the recurrent ovarian cancer, whether these PARP benefit we can observe in recurrent setting also. Apart from these, newer NCCN guidelines have incorporated the broader molecular profiling, which we have discussed many times, including I would say MSI, MMR, TMB, BRAF, and NTRK. So apart from BRCA1, BRCA2, or HRR pathway testing, so these are newer testing which are being included into the broader molecular profiling. So first point, which I'm talking about, the neoadjuvant chemotherapy role in advanced ovarian cancer. Over in a period of time, starting from the 1990, we can see there are two data basically, large robust data, SEER data and NCI. If you see the trend of usage of NACT, so it is increasing. So like green line, we can see that in after 2010, we can see that this trend is increasing of usage of neoadjuvant chemotherapy, whether it is either it is stage 3 or 4. In both settings, it is somehow increasing. There was a paper publication in which around 4,000 patients were studied, analyzed, stage 3 or 4 high grade serous ovarian carcinoma with known NSAT status, and it was published recently last year only. So this graph, we can see that survival outcome based on treatment approach. So on the left hand side, the two arm which they compared, basically one was the neoadjuvant chemotherapy followed by interval debulking surgery, and another arm was the primary cytoreductive surgery. So what they have seen that lower curve, which is dotted one, they've shown that cumulative incidence of death rate is almost equivalent, but upper curve is showing that this death rate with the neoadjuvant setting is less. On the other hand, if you see the overall survival, there is some difference between the two curves. But if there is a stage specific survival outcome, we see that on the left side, stage 3, we can see that cumulative incidence of death rate, it is higher with the neoadjuvant chemotherapy setting. Somehow on the stage 4, this is similar in both arms, neoadjuvant chemotherapy as well as primary cytoreductive surgery. And if you see the forest plot, all cause mortality, neoadjuvant chemotherapy is better in the stage 4 setting particularly, and other cause mortality, it is better in the some of the risk factor like older age group, stage 4, and more extensive disease. So these are the 3-4 sub settings where other cause mortality is also favoring the neoadjuvant chemotherapy. So crux of all these trial which I was shown just now was that utilization of neoadjuvant chemotherapy has significantly increased in older women, particularly more than equal to 65 year of age group, followed by stage 4 and stage 3 also. So women who received neoadjuvant had overall survival similar to those who had primary cytoreductive surgery, particularly in older women, stage 4 and more extensive disease. And this NSCT use was also decreased other cause mortality also as compared to primary cytoreductive surgery in older women, stage 4 and stage 4 disease. So conclusion is that the survival effect of this approach for advanced ovarian cancer may differ based on patient as well as tumor factors. So in older women, stage 4 and greater disease extent, this neoadjuvant approach was associated with similar OS compared to primary cytoreductive surgery. So another data is also showing the thing that they very beautifully have shown that 4 settings like primary cytoreductive surgery with R0, PCS with R1, NSCT with R0 and R1. So 4 subheadings. If we see that median overall survival, PCS primary cytoreductive surgery with R1 is 40 months around, and it is equivalent to neoadjuvant chemotherapy followed by R0. So wherever patients having some sort of comorbidity, older age group, and where complete cytoreduction is not possible upfront, so we can obviously go for neoadjuvant chemotherapy followed by interval cytoreductive surgery. So there were various other randomized control trial also in at various different time point, 2010, 15, 16. So all of them has defined that only in subset that neoadjuvant chemotherapy has got role. Stage 4 all patient, stage 3 some subsets. So now second point is that role of HIPEC, hyperthermic peritoneal chemotherapy. So there was a trial of OVPAC1 trial, which was published 2020 in 2020 International Journal of Gynecology Cancer. So stage 3 ovarian cancer patients were taken roughly 245, 3 cycles of standard chemotherapy were given, paclitaxel. Then there was a 1:1 randomization with the interval cytoreduction with HIPEC. In this, they have used a regime of cisplatin only 100 milligram per meter square. Although there is a literature for various regimes, but I think for ovarian, this is the most commonly followed regime wherever HIPEC is being done. And then followed by the 3-cycle paclitaxel carboplatin was completed, and then follow-up was seen. So if you see the result, that this red curve is showing the HIPEC one, and blue one is the only cytoreductive surgery. So HIPEC is definitely showing some survival advantage, but along with that, there was some drawback in this study. Stage 4 patients were excluded, and majority of stage 3 could be primarily debulked to less than 1 centimeter. OS was not a primary or co-primary endpoint. Small study size can induce significant bias, obviously, and HIPEC toxicity appeared to be underreported in this trial, particularly despite longer operation times, longer hospitalization period, more perioperative stomas, and vague reports on adverse events. There was another study also, which was published as a abstract form only in 2017. Here also, in some of the subgroup where neoadjuvant chemotherapy was given, they have shown some benefit with the HIPEC, and so perhaps HIPEC was used as a tool to compensate for insufficient cytoreduction in some of the studies. So, and there was another study, 276 patients. Again, in this curve, we can see that very clearly they have shown the benefit with the HIPEC. If we combine with the surgery, in terms of recurrence-free survival as well as overall survival, with good hazard ratio 0.66, but again, some drawbacks were there in this study. So I would say that HIPEC is not very well accepted, at least in our faculty. So obviously, some people are doing, some surgeons are doing in selected subsets. So there was a guidelines by the ESMO ESGO consensus conference regarding this HIPEC. The only randomized controlled trial on the effect of HIPEC in recurrent epithelial ovarian cancer has been widely criticized, and a meta-analysis or retrospective study in this scenario did not show any survival advantage, but rather an increase in adverse event was seen, anemia and acute kidney injury, precluding the HIPEC from standard of care. So this guideline also says that it cannot be considered as standard therapy as of now, although it can be considered as a part of some large trial. And until now, there is no appropriately designed prospective study on the effect of HIPEC added to the secondary cytotoxic surgery in recurrent ovarian cancer. So, role of this HIPEC is also limited in today's scenario. Third point is extending anti-VEGF inhibitors. So, whether if we use the bevacizumab, we can increase the survival outcome or not. So these are old studies which we are practicing in our day-to-day routine practice. Icon 7 study, GOG 218. So when we add the bevacizumab to the chemotherapy, they have shown to be an active agent in hard to treat patients with advanced disease. So Icon 7, good number of patients, 1500, GOG 218, 1800. So 6 cycle of chemotherapy, placebo arm, control arm in both sides. And experimental arm was bevacizumab, slightly dose difference was there. 7.5 milligram per kilogram in the Icon 7 and 15 milligram per kilogram in GOG 218. And in both study, I believe they were given at 3-weekly interval and followed by the maintenance. I think maintenance schedule also was somewhat different. In Icon 7 was given for around 12 months after completing this 6th cycle, and GOG 218 was additional 22 months after this adjuvant. So what was the highlighting point of these two trials, that they have shown the significant PFS benefit, but there was no OS benefit in the intention to treat population. As we can see that median overall survival is almost similar in both arms, in both trial setting. But if we segregate the patients in Icon 7, the high risk versus all patients. Upper curve is showing that all patients, if we take bevacizumab and standard chemotherapy, are showing the similar outcome in terms of overall survival. But in high risk setting, that bevacizumab has done good job and it's showing the better outcome. On the right side, this flow chart is very beautifully have shown that high risk definition is slightly different in both Icon 7 and GOG 218. In Icon 7, if we see that they have defined high risk as all operative stage 4, unoperated or suboptimal, means more than 1 centimeter stage 3. On the other hand, GOG 218, they have taken suboptimal more than 0 centimeter. Like any residual disease stage 3, they have included into the high risk. So if we talk about particularly GOG 218 stage 4 subset, so we can see the curve. There are 3 curves they are showing, that one is chemotherapy plus bevacizumab followed by Bev maintenance, and this is showing the best outcome in terms of median overall survival, that is 42 months, which is 10 months higher than the chemotherapy plus bevacizumab followed by the placebo, means where no maintenance of bevacizumab was given. So since then, this has become the standard of care, at least in stage 4 and some subset of stage 3 also. If we talk about recurrent ovarian cancer, there was a 3 trial which are oftenly discussed: Aurelia for resistant setting, Oceans trial for sensitive, platinum sensitive setting, and GOG 218. So all of these 3 trials have shown consistent PFS benefit with the bevacizumab if we use in the as a maintenance, but no OS benefit was seen in any of these trials. So that was the outcome in the recurrent setting with the bevacizumab. Now we come to the main highlighting point of this talk, that was a targeting part, survival benefit with the latest update which was presented in this recent ESMO 2022. 2 settings, both were in first line setting, and first trial was the Solo 1 update and second was the Paola 1 update. First was the overall survival at 7-year follow-up in patients with newly diagnosed advanced ovarian cancer and the BRCA mutation positive who received maintenance olaparib in Solo 1 trial. And background 10-year survival, we all know that in newly diagnosed cancer, this type of setting is around 17%. Relapse setting is typically incurable, highlighting the need for more effective therapy. In Solo 1, maintenance olaparib has provided sustained benefit beyond ends of treatment, which was capped at 2 years as of now in women with newly diagnosed advanced ovarian cancer and a BRCA1 and BRCA2 positive patients. So after 5-year follow-up in SOLA 1, 48% of patients in olaparib arm versus 20% placebo were progression-free. So this update is about the OS analysis after 7 years of follow-up in SOLO 1. So this was the treatment schema of this trial, and we all know that newly diagnosed FIGO stage 3, 4 high-grade serous or endometrioid histology were included, ovarian primary PPC or fallopian tube cancer with BRCA mutant positive, good performance status, cytotoxic surgery was done, incomplete clinical response or partial response after platinum-based chemotherapy. So there was 2-arm, 2:1 randomization, olaparib, that was the experimental drug at that time, 300 milligram twice a day standard doses, roughly 260 patients, and placebo 130. So primary endpoint was PFS, secondary endpoint was overall survival, treatment to time to first subsequent therapy. Another was the time to second subsequent therapy, and then the safety analysis. So here another highlighting point is that they have continued, they have given the option to continue the olaparib even beyond 2 years if patients is showing good outcome and there is some residual disease. So it was kept with the it was the investigator treatment physician decision, and first data cutoff point was in 2018 when the first outcome was published, and second was 2020, and with which updated PFS was published. In both outcome, they have shown the good outcome. 3-year PFS was almost doubled, 26% with the placebo, 60% with the olaparib, and this benefit was being maintained even at 5 years, 20% to 48% with the olaparib, with good hazard ratio. So then they analyzed the data in a more refined way, like 7-year analysis was designed, and last analysis was done in the 7th March 2022, and it was around 7 years since the randomization. So if we talk about detailed demographic profile of 2-arm, olaparib as well as the placebo arm, so male chunk of the patients were stage 3, 80% roughly, stage 4 were 15 to 20% in both arms. So well balanced, and BRCA1 was obviously a higher percentage, 70%, and BRCA2 was 25%. And regarding surgery, upfront surgery or some residual disease was also seen in some of the patients, 20% of the patients, and some patients had undergone the neoadjuvant setting, followed by the debulking surgery, interval cytoreductive surgery, in around 30% of the patient in both arms. And patient disposition at 7-year cutoff point, they have seen that randomization was 260 in this olaparib arm, and discontinued treatment before 2 years, roughly in around 42% patients. Completed treatment in 2 years, 47% patients. So this was the disposition at 7-year timeline, and objective disease progression was there in 20% of patients, and median duration of treatment was 24 months. As I said, in some patients, more than 2 years was also allowed. So this is a maintenance olaparib which have shown that clinically meaningful benefit in the OS. Even at 7 years, we can see that 5 years that was seen, which you were seeing earlier. In previous years we are seeing. Now at 7 years also that difference, in fact curves are more separated at 7 years, 46% with the placebo, and we can see that 67% with the olaparib at 7 years, and this difference is still continuing beyond 7 years. And time to first subsequent therapy is also higher with the olaparib arm, and even time to second subsequent therapy is also higher with the olaparib arm, which we can very well see in this curve. No new safety signal were observed after 7 years, means any median duration treatment, we know that it is roughly around 2 years. Treatment related adverse event more than grade 3 was seen in 40%, serious adverse event was seen in 20%, and discontinuation rate was around 11% in the olaparib when we see the primary PFS analysis. So if we compare with the 7-year OS analysis, so data which was seen is almost similar. So it is nothing much difference in between the two, between 2018 or 2022 in terms of dropout rate. So and some special side effect, we know that MDS AML were also similar, 1%, although new primary malignancy was higher at 7 years. Earlier it was around 2%, but now they are showing that 5% new primary malignancy at 7-year analysis. So all these side effects, we all know that light pink color is showing the all grade side effect, dark red is showing the grade more than grade 3 or 3. So which is worrisome. In some of the patients, anemia is grade 3, 20% patients, and neutropenia is around 8.5%. So diarrhea is also there, and fatigue, asthenia. So these are 4-5 side effects which is worrisome in some of the patients, and then they are managed with some type of dose reduction. So conclusion with this solo one is that it is a first study to demonstrate clinically meaningful, not statistically significant due to the alpha assignment, some statistical term. There is improvement in OS with PARP inhibitor maintenance monotherapy in first line setting, and 67% of the olaparib patients versus 46% were alive at 7 years. So roughly around more 25 to 30% more were alive at 7 years with the olaparib, and similarly all these things were improved with the maintenance olaparib, like time to first subsequent, time to second subsequent. So this is the data, most robust data among all the PARP inhibitor. Now we come to the Paula 1. So about this also there was an update regarding final OS analysis at 5 years, and basically this trial is about combining the olaparib along with bevacizumab in the maintenance setting in upfront newly diagnosed advanced ovarian cancer patients. So similar type of settings as the solo one, but just they have added the bevacizumab in newly diagnosed advanced ovarian cancer who have received first line standard of care treatment including bevacizumab. So in primary analysis, when it was published earlier, this combination has demonstrated a significant PS benefit over only bevacizumab, mainly in those patients where HRD positive was found. So this final Paula 1 have shown the again same PFS advantage being maintained as well as the OS advantage also. So this is the treatment schema, more or less similar as the solo one, and randomization was done after 9 weeks of this completion of adjuvant treatment. Again 2:1 randomization with the olaparib tablet, standard doses 300 milligram twice a day along with bevacizumab, and followed by the primary endpoint, that was the PFS, and secondary endpoint was PFS2 and overall survival analysis. So this was a statistical schema with which they came to the demarcation that final OS data cutoff point they have kept 22nd March 2022, recently only, and demographic profile on these two arms were well balanced as we have seen in the solo one also. Highlighting point in this Paula one that stage 4 patients were slightly higher, 30%, and upfront surgery was done in 50% of patients, and 40% patients do have residual macroscopic disease, yeah, partial response was seen in 25% of patients in both arms. So patient disposition at final data cutoff in 2022 at 5-year timeline. So median duration of treatment was roughly 11. So it was 17 months in the olaparib plus bevacizumab arm, and follow-up period was 60 months. So this was the OS analysis. We can see that 5-year overall survival, it is around 6% higher with the combination arm as compared to Bev alone.
So would request you to conclude your session in 2 minutes.
Yeah. So just 5 minutes. So our overall survival was prolonged in the HRD positive subgroup if we demarcate apart from the intention to treat population. So this benefit was more pronounced in the HRD population, and even PFS, updated PFS was also more robust in the HRD positive subgroups. So this is very well showing the summarization of this Paula one. On the extreme left, we can see BRCA mutant is there more benefit, 53 point versus 73% 5-year OS rate. Some benefit with the HRD positive excluding BRCA mutant, and HRD negative there was not much significant benefit was seen. So the conclusion of this trial we have discussed, 5-year overall survival is better with the combination of arm, and PFS benefit was also being maintained. So recurrence ovarian setting, just 2 slides. Solo 2 trial, Nova and Ariel 3. So they are trying some other PARP inhibitor, niraparib, rucaparib. I think they have also been approved in recent times, and we can see that curves are really separated for this setting also. In recurrent setting, if we use the maintenance as a maintenance, these all PARP inhibitors. So PFS difference is also better with all these drugs, particularly in the where we find the BRCA mutant positive. So solo 2 in recurrent setting, olaparib maintenance is also showing the good OS benefit Around 10% difference is there in solo 2. Another was niraparib. So this was phase 2 trial, and this also have shown that this combination drug, if we combine niraparib with bevacizumab, showing the around 8 months benefit over and above the bev alone. So 7-month benefit was seen in this trial. So to conclude my talk, patient treated with neoadjuvant chemotherapy should be those with comorbidity unfit for surgery, or those where optimal complete cytoreduction is not possible. And Bev-based therapy has profound effect on PFS of both platinum sensitive as well as recurrent setting. PARP inhibitor has proven their role. Even more robust data has been published. Immunotherapy is still under consideration. Thank you. Over to the organization.
Sir, for the very informative talk on the role of PARP inhibitors in ovarian cancer. In your experience, what has been the side effect profile of olaparib till now?
Yeah. So what I observed that more common side effect was the gastritis, this anemia. Anemia is worrisome. Because of that, we have to reduce the dose of olaparib. And in some of the patient, I have to drop completely even after reducing the dose to first or second level also, 100 milligram twice a day. So some patients are not tolerating. So anemia is really worrisome in some of the patients. Even I have tried, although it is not recommended, darbepoetin also in 1 or 2 patients. That also has not, with that also I am not able to continue the same dose of the olaparib. So although this patients are around 5-7 patients I have tried, so that is a limited data with me.
Okay, but then you, I think, do believe that olaparib is a game changer in the treatment of ovarian cancer, be it the upfront setting or the recurrent setting.
I think I'm more comfortable in using the upfront setting rather than the recurrent setting, because my personal experience in recurrent setting is not that good. Maybe I've used in recurrent setting in third line or even beyond. So correct alignment with the current trial, I have not used in, at least in recurrent setting. So I'm more comfortable in primary, like upfront setting only.
Okay. Right. Thank you so much for this talk, sir. Stay with us for the rest of the session.
Yeah,
Thank you. So after this talk, we move on to how to treat ovarian cancer post and beyond PARP inhibitors. We had a talk by Dr. Rama Joshi, but she could not be with us. She had an emergency surgery to attend. So we are going on to the session for treatment of ovarian cancer beyond PARP inhibitors. And to talk about this, we have with us Dr. Vikas Salreja, who is a senior consultant medical oncology at Regency Hospital in Kanpur. Dr. Vikas, hi, good evening, and over to you.
Very good evening. I'm sorry I posted some wrong message in wrong groups. There's the problem with the phones are that right now that there are multiple messages coming right away. So a very important point highlighted by Dr. Deni sir was regarding the PARP inhibitors, and across various indications, across various settings, I believe they have shown their time-tested regimen. We believe that it is very important that we put them into, because reality in practice right now. But as we keep on learning, we keep on exploring to what are the right patients, when to start, whom to give, and how to give. And there's always a gap in practice in terms of the PARP inhibitors. But the next gap that is going to come is by the what after the PARP inhibitors. I will specifically look out of the HRD definition, as well as the trials which have taken, whether the testing of the alteration in the HRR pathway related genes was there, whether there was a genomic scars, that is loss of heterozygosity, TAI, LST, methylation status, functional assays, and PARP inhibitors in futures, and what after next. So next slide, please. As we go into this, many times in our current practice, we have seen the PARP inhibitors. This was the study, that's the ORIO study for us, basically, which showed that after the platinum re-challenge, PARP re-challenge is definitely possible, where according to the BRCA mutation status, you could see that there was a statistically significant PFS benefit was observed with those with olaparib in the BRCA mutated cohort with an hazard ratio of 0.57, meaning a 43% reduced chances of progression when you add olaparib in those patients who are BRCA mutated after the platinum-based therapies. But in case of non-BRCA mutated population, also you could see there was a statistically significant benefit observed after you give a platinum rechallenge and a PARP inhibitors maintenance with an hazard ratio of 0.43, meaning a 57% reduced chances of progression. In explorative analysis, benefit in the non-BRCA mutated cohort appeared consistent irrespective of the HRD status. So whether you were HRD positive, you did a similar magnitude of benefit, and whether you are HRD negative, you derived a similar magnitude of benefit. So non-BRCA mutated, HRD positive or negative, the magnitude of benefit was nearly 40 to 40 reduced chances of progression when you add to the maintenance of this. To summarize, HRD testing in platinum-sensitive population, most recurrences will occur after the discontinuation of PARP inhibitors. Therefore, there is a limited duration in the first line. Limited study was there with the patient enrollment. So PARP exposure is not equally exposure to the PARP resistance. So even though we're giving PARP drugs, but then it doesn't mean they are having a resistance to it. Therefore, we need to select those patients, identify potential mechanisms of resistance to the PARP inhibitors. So what we do, a very beautiful study has been into action is the EVOLVE study, where post-PARP inhibitors, the archival or the previous therapy are reviewed, and the patients based on the platinum sensitive, platinum resistance, or prior PARP exposures treated with the further chemo in between. They are given re-challenge with the PARP inhibitors, re-challenge with anti-angiogenic agents, and the clinical outcomes were seen all across these graphs. So what were the resistance mechanisms that were found? The reversion mutations in the HR genes, that is BRCA1 and 2 and the RAD51, the amplification in the CCNE1, the upregulation of the multi-drug efflux pump gene ABCB. Therefore, patients with reverse mutations in HRD genes had the worst outcomes. Multiple mechanisms of the DNA repair functions PARP inhibitors. And that's where comes this aerial 4 study design, where relapsed high-grade epithelial ovarian cancers with more than 2 or 3 platinum-based regimens with a deleterious BRCA mutations and either no PARP inhibitors or agent paclitaxel treatment were given, and they were randomized into the rucaparib or the standard of the chemo. If it was platinum resistance, they were or partially platinum sensitive, paclitaxel was there. If fully platinum sensitive, it was the single agent platinum that was being given to them. And the BRCA reversal mutation subgroup was seen deriving a maximum benefit with the chemotherapies. So 5.5 months of the median PFS with the chemotherapies as compared to 2.9 months with the rucaparib. And you could look at those exceptional responders, especially the 7 years, as you could see. This patient had an prior therapy with cisplatin, paclitaxel, carboplatin, and gem-carbo, and there was a partially platinum sensitivity, and was started on a clinical trial with olaparib and had an excellent disease control till 2012. And there was a single site recurrence, and again that recurrence was addressed and was continued on olaparib until 2015, when she had a progression, and then she had a progression on chemo also, showing that this PARP inhibitors do have a very important play, especially in the platinum sensitivity subgroup. And if we look at these molecules across these resistant mechanisms, you could look at the BRCA expression and the CCNE expression PARP failure does tends to increase with this. Therefore, the disease do tend to get evolutionized. Even though the clonal evolution is a conceptual, it does become into clinical reality in the some part of the treatment. The PARP platinum resistance is considered equivalence to the PARP resistance, and therefore the need for the combination strategies and developing new tools to identify potential mechanisms of resistance is there. So various strategies to prevent the resistance to the PARP includes the combination, that is, you modulate the environment of the microenvironment, and that's where these three studies have a very important role, where along with the PARP inhibitors, you give them the platinum and the bevacizumab, the best drugs available on drug, along with the immunotherapies, the EGODIO, the first, the ENGOT-1 trials. I think also included the platinum chemotherapies followed by the maintenance either
sorry to intervene. Are we on the right slide right now?
You need to go a lot beyond, because should I share it from my screen? Next to next. There you have waved 10 slides more. Next. Yes.
Okay,
yes,
sir.
sir. So why different roads but all leading to the same destination? The mechanism of resistance is somehow there is the restoration of the homozygosity, there is the replication fork protection, there is single transduction pathways, and there is a regulation of the drug efflux. All of these combining together plays a very important mechanisms for the PARP inhibitors resistance mechanisms. And therefore, the newer signal transduction pathway, which is being commonly targeted, the next slide, 3CA pathway, where there is a phase 1 study of combining olaparib with alpelisib, especially in ovarian cancers. A phase 3 trial, it is ongoing with no germline detected. You could see those responses are and very deeper clinical responses, even though it's a phase 1 study. But yes, this does show a very remarkable potency. Now, there are newer and newer targets that are being discovered, as we could see, even though it's a very cramped slide. Next slide, please. There are ATR inhibitors, that is goes by the names of berzoterib, serelstat, and there are 3 other molecules. Now, another CDK2 inhibitor that is in development, especially with the cyclin E inhibition pathways, is the dinaciclib. Now, a very important molecule is the CHK2 and CHK1 inhibitors, which is the plexatinib. That's also shown a very important promising phase 1 activities. Down regulation to the PARP is the DNA PK, where the nedicertib and the AZD7648 works. Now, also, there has been multiple clinical trials, phase 1 and phase 2 right now, for the challenge giving in ovarian cancers, the CDK4/6 inhibitors, as they come downstream to the PARP pathway, the palbociclib, ribociclib, and abemaciclib. There is again a very important efficacy for the RNR inhibition by the trypine molecule that's being there. So a lot are coming in domain, and we would be looking into this cell cycle very deeply. Next slide, please. And the age-old molecule is our gemcitabine, as we could always use that drug. The antimetabolite that inhibits the DNA synthesis, especially in our highly resistant platinum population. It has been combined with the plus AZ D7775, the same molecule which I told you was considered the downstream to the path inhibitors. And you could look at the response rates. Next slide. Nearly 23% of the patients was with the gemcitabine AZ combination had a very good response, a deeper response, and a much better response as compared to single agent gemcitabine. You could look at the spider plot also, the durability of these responses are continuing. If you look at the progression-free survival, again, 4.5 months with the combination as compared to 3 months again with the gemcitabine alone, and also 11.5 months for versus the 7 months with a hazard ratio of 0.56, meaning a 44% reduced chances of deaths when you give these combination of the drug. That is edovasertinib plus gemcitabine as compared to gemcitabine alone. And this is the key tumor alteration that the edovasertinib usually acts, especially in the CCNE1 overexpression, which is one of the most common mechanism of the PARP inhibitor resistance. And you could see a phase 2 signaling trial also with the edovasertinib in recurrent high-grade serous ovarian cancers with CCNE overexpression with or without amplification for the same. Now, if you look at the results of also this phase 2 trial, you could look at the encouraging response of overall response rate of around 53%. Next. Yeah. So that also, and you could look at the cyclin EN1 score, which is commonly used right now for targeting this thing. All of them had a cyclin mean score of around 120 with a copy number of around 3.2. So definitely effort trial where the post-PARP inhibitors, you could see that edovasertinib plus olaparib also are being given so we could look at the edovasertinib plus the olaparib combination in the recurrent ovarian cancers, especially in the phase 1 study, where you could look at unlimited prior therapy being given, look at those responses. There were very deeper responses. If we look at the objective figure, around 40% of the patients did have some response with the combination of this. And if you look at the several ATR inhibitors trials, there is these drugs, berzotrip, seralstrip, elimustrip, and RP350, 3500 are those trials. The Capri trial, where the seralstrip plus olaparib was given in platinum PARP-resistant ovarian cancers, you could look at the response rate. Again, a very deeper and a very good response rate, especially when the seralstrip 160 milligram once daily was given day 1 to day 7 with olaparib combination, and you could look at those tumor responses. Also, the berzotrip plus gemcitabine given had a objective deeper response rates as compared to gemcitabine alone. So these are some of the potential markers. Next. You could look at the CNE1 amplification, the CD cyclin D kinase 2A copy number loss, the KRAS mutations, the NF mutations, the MYC amplifications, the ERBB amplifications, and also the phase 1 trial of the ATR inhibitors, which is ongoing, also very, very important. So at the end of the talk, I would say that there are a new and newer molecules. Immunotherapy also has come a lot, especially in the DDR and the DDR combos, where you could have the efficacy of these drugs with the newer PD1 and PDL1 inhibitors. There is a new PARP inhibitor that's also coming. That's a new generation of the PARP inhibitors, which is selectively inhibitor of the PARP1, which is more targeted and more efficient and less toxic. And early phase trial does show its efficacy across the HRR pathways, be it BRCA1, BR2, PALB2, RAD51C, or RAD51D. We have to look at the improving the drug delivery by combination of the antibody drug conjugates next, where we see more and more degrees of genomic instabilities, higher intertumor and intratumor heterogeneity, hypoxic and immunosuppressive tumor microenvironments. All of these parts are being right now explored. This publication was done in Lancet, and it shows that yes, drug delivery will play a very important therapeutic efficacy post-PARP inhibitors. So to conclude, a new area for ovarian cancer is the PARP inhibitors, which is DDR inhibitors, which are just the tip of the icebergs of the therapeutic opportunity. We have to target the primary or the acquired HR deficiencies, prior therapies, disease evolution, potentially new targets. Very important is these cyclin inhibitors, which I talked. The combinations are here to stay, and the schedule and the balance and with the toxicity and improving drug delivery is very, very important in near future. Thank you for patient listening. I am here for, and thank you organizers for providing the platform.
Dr. Talreja, for this very futuristic talk, I should say, on how to really go about treating our patients beyond PARP inhibition. I believe there were a lot of pathways that you talked about, which are new to all of us. And in this ASCO 2022 also, there were few data sets to suggest that probably the BRCA reversion pathway or the MRE pathway will be the pathways which will be targeted in the drug development beyond PARP inhibition in times to come. So I want to ask you one question, that all the new targets that you've spoken about, how to really go about discovering these pathways? Is it more about rebiopsy? Are we going to rebiopsy our patients, or is it more about the cell-free DNA? Any thoughts on that?
So all of these, as you could see in the evolved study, most of them went back to the archival tissues and found out mutations for what would be the potential mechanisms of resistance. But yes, some of them, these trials does include a fresh reset of biopsies, a fresh reset of circulating tumor DNAs. But these are going back to the molecular pathways downstream to the PARP. So essentially, as you could see, there was one where you could go to the cyclin D numbers and the copy numbers, and then give the potential adovasertinib to the combination of the olaparib or gemcitabine. And therefore, newer and newer potentially mechanisms are being explored in multiple phase 1 and phase 2 studies right now, as you could see. Till the time we have a very good phase 3 and a phase 4 recommendation, I believe we are all in awe for waiting for what could be the next drug on a Monday morning post PARP inhibitors. But yes, there are plethora of options right now. Newer PARP inhibitors, CDK4/6 inhibitors, newer drugs, newer mechanisms. There are plethora of options potentially too. I believe a conference would be sufficing for the same.
Yeah, I agree. And also, one would tend to agree that these newer pathways that are being discovered, they are just probably the tip of the iceberg. There are so many things that one has to learn in these newer pathways, and we have seen that over the years with EGFR pathway, or for that matter, AKT-mTOR pathway, that many a times the drug development it relies a lot on how we really understand those pathways. So probably it's going to be a learning curve for all of us, but it's going to be certainly interesting for us as medical oncologists to see as to what is going to be the drugs beyond PARP inhibition, and how are they going to improve the survival of our patients in ovarian cancer. Right. Thank you so much for this talk once again. So we move ahead now, and after these talks by all our expert faculties, we go on to the panel discussion of the evening, which happens to be on the management of advanced ovarian cancer. How do we really take things forward in 2022? And to have this panel discussion, we have with us Dr. AVS Suresh, who is our moderator for this panel discussion this evening. Dr. Suresh is a senior consultant hemato and medical oncologist at Continental Hospitals in Hyderabad. Dr. Suresh, good evening.
Good evening. May I invite the panelists to unmute themselves, please? And
yes,
can I have the slides?
Yeah.
Thank you, Rajat, for the invitation. It was indeed a very, I can say, insightful information.
So I would request all the panelists to switch on their videos so that we can have an interactive discussion.
Is there any audio problem with speaker? Excuse me.
I think we are not able to listen to Dr. Suresh's voice.
Yes, sir. Please unmute yourself. So, Dr. AVS Suresh, sir, you need to unmute yourself. Sir, you are muted.
No,
You
he
need
is
to
muted.
unmute.
No.
There is some problem. Yes. Technical support team, can you guide Mr. Suresh?
Hi, Anuj.
Oh, sir. How are you, sir?
I'm fine. It's good to see you after a very long period of time.
Same here, sir.
You still look same, huh? It's been like 3-4 years, huh?
Yes, sir.
So,
I guess his audio system setting is different, right?
support team, can you guide Dr. Suresh?
He was audible initially, but
yes, ma'am.
Support team, please guide Dr. Suresh. He can hear us, I think, but he is not able to.
Suresh, sir, please use a headphone, sir.
Dr. Suresh is joining back again.
Miss Pooja, you can ask him to leave and
Can you hear me now?
Yeah.
Okay?
Now.
Yes, sir. Yes. Sir,
Okay,
yes.
I just logged off and logged in. I'm so sorry for the technical glitch. Once again, thank you for sharing giving me the opportunity and then sharing my small case for a panel discussion. Can I have the slides, please? Someone? Wonderful. Right. Thank you very much. So this is a 55 years old woman presented with abdominal distension. Ultrasound was showing adnexal mass with ascites. And as usual, they did all the serum markers and CA125 is elevated. And these are the findings, classical of a locally advanced ovarian cancer. So just a quick question with these things. How many of our surgical colleagues in the panel would like to operate on him? And how many would like to refer to a medical colleague? Are there any surgical oncologists in the panel? I guess they are, right? If they are not, that someone can take up the question, please.
I guess there is no surgical oncologist.
Very essential in ovarian cancer, right? They are the people who cure and we just palliate them. Yep. So this is a case. Can you go to the next slide, please?
We all are medical oncologists in the panel, right?
Absolutely right. So, but we have to acknowledge our surgical colleagues that they are the best in curing the ovarian cancers. Even if it appears to be pretty advanced, the first preference have to be given to for the surgery. I hope most of our colleagues will agree for this, right? And this is a graph which was published in the International of Gynecology 2020. that irrespective of the age, the comorbidity index, grade, histological type, if you do surgery first, they did better compared to if you give neoadjuvant. Any difference in the opinion from anyone?
No, I have.
Please.
Absolutely agree with you, sir.
Right.
Only thing is that we need to choose patient wisely for the neoadjuvant chemotherapy. And the indication for neoadjuvant chemotherapy, as have been highlighted by the previous speaker, is that poor performance status and very extensive disease.
Right. So completely agree. So poor performance status is one thing, and probably age is one thing that you always have to keep it in mind. These are the only two factors in the meta-analysis which showed that, that favor more towards neoadjuvant chemotherapy rather than upfront surgery. And if you look at primary cytoreductive surgery R0, R1 versus neoadjuvant R0, R1, the surgery upfront did perform very well. So next slide, please. So the patient underwent the surgery as
Dr. Suresh, I want to make a comment here. We generally see these major trials happen in the Western countries where the supportive care is much more different and intensive than our setting. So doing a very extensive surgery, like they do the 9 to 10 or 12-hour surgery. One of my patient from abroad, they came and said like she underwent for like 15 to 16-hour surgery.
Right.
So that much prolonged surgery is just is beyond our imagination, and post-operative care in ICU and everything is very different there from here. And such a mutilating surgery, after that, patient's survival may be better, but the quality of life is definitely going to decrease. So there is not a bad idea to give anesthetic. If the disease is so advanced and it is taking like too long to do the surgery, and we don't know the outcome after that, like in our setting and their setting, it's not just comparable.
Right.
So our ICUs are loaded, and if you see the space between two beds in our setting and their setting is entirely different. And paying capacity of our patients are also very different. Like they can't spend 5 to 10 lakh rupees for the ICU stay, but they can spend. So my point of view is little different, but science says like whenever possible, whenever PS allows, we should go for the upfront surgery. That I agree. But mostly, even if you see in our panel, 80% time we'll end up with the giving anesthetic and in advanced setting and then doing the surgery.
So I take your point on 1, 2, 3. Let me summarize. 1, most of our patients do have a very poor performance status, malnourished. They are not as well built as in the Western population. So the ability to take the long durations of surgery is a challenging thing. And the moment you give chemotherapy, their general condition improves, they become better, they can take the surgery well. Point very well made and then very well comprehended. Point well taken. So here, the argument which the Western people have is, if you give chemotherapy, you are postponing the surgery, thereby giving a chance for inferior survival. And if you look at the actual data, the graph starts getting separated after 8 months or 9 months. So the immediate mortality is maybe slightly higher there. It's there also. I mean, we don't know exactly. So why the graphs were very close in the beginning, but after a point of time, they start separating. If you look at the previous slide. So point well taken, sir. But this patient, very well preserved, underwent surgery. Just, I thought a surgeon is there on our panel. That's the reason I put few of the questions. So they underwent lymph node, para-aortic lymph node dissection. So this is where most of the controversy happens in the surgical discussions when we see. So just let's have a look into next slide, please. Next slide. Am I the person? Yeah, thank you. So in this stage, the para-aortic lymph node dissection, is it really required or not, is one question that was never answered, but few people still believe that it is going to improve the overall survival in a subset of the patients. So the goal of the surgery in this particular case was R0 resection. Probably laparoscopy helped the surgeon to have extra confidence. And the lymphadenectomy was controversial, but the surgeon went ahead and then did the surgery. And as we rightly told, in our
Dr. Suresh, it was enlarged node in the CT scan. So clinically, that was enlarged node quite a large. I guess it was 2 centimeters
very
around.
Big.
If you see the visual impression, so they needed to do it. So they did right thing.
Exactly. So, but the lymphadenectomy was controversial, but in this case, it was indicated. I'm telling you, there is a subset of the patients, definitely it's going to prolong the survival. So 3 cycles of neoadjuvant therapy we do use in our practice. Next, please. So this is a line trial, right? A line trial. We discussed already about this. You can skip this. So this is where we see that with lymph node dissection, without lymph node dissection, there is not much of a difference, right? Next, please. So what is the standard of treatment for the newly diagnosed advanced epithelium? Depends on many factors. We rightly told fitness, histological subtype, volume, setting, and reimbursement guidelines. Next, please. In case, next, please. In case, this is a case which underwent surgery, the patient was perfectly fit. So what is the best choice of this patient at this time? I'm giving 5 choices. Probably we can just have a short discussion. Paclitaxel, bevacizumab followed by bevacizumab maintenance. Paclitaxel followed by niraparib. Paclitaxel, do a BRCA testing, then positive, then go for either olaparib or niraparib. And Paclitaxel, bevacizumab, HRD testing, then positive, go for a combination of bevacizumab with olaparib. So these are the 5 scenarios in front of us. Let us discuss pros and cons and why each of the panelists feels which is better sort of. Probably we can just go with Dr. Asim, please. What is your choice in this case?
So nowadays we are doing upfront testing of the BRCA, and nowadays we are added HRD also. So if it is positive, then the case is very simple. We should give paclitaxel and then olaparib maintenance. Suppose but patient is negative, then we might think like paclitaxel, bevacizumab and bevacizumab maintenance. And
don't
if
want
you want
to add bevacizumab, that is paclitaxel bev followed by niraparib or olaparib. You don't believe that?
Niraparib can be given in both the situation. It's a primer trial says like it doesn't require any BRCA1 positive or not. But niraparib is not available in India right now. So, and we don't have much experience about this drug. So I am not commenting upon that. And how to get it is also very difficult.
Yes.
So for our scenario and setting, if the patient is BRCA negative, we can go for the paclitaxel, bevacizumab and bevacizumab maintenance. But one option is certainly according to the Paula trial, we can aid if they are negative, bevacizumab, olaparib also is an option. But the cost is again a factor. So if positive, aid olaparib in maintenance. If negative, then bevacizumab and bevacizumab maintenance is my choice.
Abhishek, what is your take on this, sir?
I completely agree with Dr. Asim, and if the patient, we have to test for BRCA and HRD, and if they come as positive, we can give the option according to the Paula study or maybe a Prima study. Prima study, we do not need any positivity of the BRCA status, and carboplatin paclitaxel followed by niraparib is another option. Bevacizumab only as a maintenance in this patient. Only one thing is there as ascites. Ascites was present, so based on ascites presence, we can give the bevacizumab maintenance as well. However, they have not shown a survival benefit. Carboplatin paclitaxel along with bevacizumab followed by bevacizumab maintenance. So it all depends on HRD and BRCA testing, based on which we have to give the best choice for the patient.
So understand, ascites is a very interesting point that you got into the picture, Abhishek. So point very well taken, So Dr. Kaushal, so let us assume that this patient can't afford anything. Are you still comfortable in giving paclitaxel and then go with the maintenance of either taxanes? You never believed that taxane maintenance had any impact in this? Choice A sort of thing.
Yeah, if you ask me as a whole, then I would like to go with the option number E.
paclitaxel, carboplatin, bevacizumab, and if HRD is positive, then I would like to go with the beva plus olaparib. If you have asked me if the patient is not affordable for anything, then I would like to go with the paclitaxel and carboplatin required cycles. That's it. I would not like to go with any maintenance therapy.
So what is the big difference that you saw over a period of time? Anyone can just take from the panelists. The impact of bevacizumab versus, I can say, new PARP inhibitors in the quality of life versus the quantum that they prolong the life. So few people are, I've been practicing since 2004-5. So I'll just share my experience, but I would like to hear from the panelists. So did it double? Did it triple? Did it really made an impact in the quality of life? So let's keep aside the data. What is their personal experience? We'll start with Dr. Asim.
So in my experience, if patient has heavy burden disease, like this patient also I would count in that, but especially the stage 4 disease, bevacizumab has proven the survival advantage. The data of GOG 218 trial, they had shown like the survival was double in that case. But still, if patient is 3C in this case, I would like to give because patient had ascites, and in ascitic patient, bevacizumab works very well, and to maintain with the bevacizumab maintenance therapy. And it has no great symptom or side effects after the bevacizumab. Patient doesn't have alopecia or BP. We can take care of the antihypertensive medication. So really, in upfront setting, there is no great difficulty in dealing with this drug. And the schedules are very flexible. A patient is coming 3 weekly, it's fine. If coming 4 weekly, still is fine after a major period of time. And it's not very costly now because it's available in the major pharmacies. It's a very cheaper rate nowadays. So in my experience, it is good drug. But suppose this drug doesn't work in the adjuvant setting in this case, or maybe in the usually upfront 4th or 5th cycle, then you obviously you will not give bevacizumab maintenance. But if the effect is good, then you can continue with this drug. And we are always talking about the median PFS. So median PFS is sum of patients who are not responding and who are responding, who are greatly responding. So it is in between line. So the trial has shown like 3-4 months benefit in the PFS, but still if the patient are responding, the benefit are sometimes quite a long period of time. So if the science permits, if p-value was significant in the trial, nowadays cost is also permitting. So might as well use this drug. It's no harm in using that.
Wonderful. Abhishek, you brought in a point of what we call as a ascites and bevacizumab. So in presence of ascites, what will be your choice if BRCA testing comes positive?
So we can give the option of bevacizumab olaparib combination for such patients.
Right. That is option You're right. Anuj,
the overall survival benefit, I don't think both the trials GOG 218 and ICON-7 are shown a survival advantage. In the subset analysis, initially they have shown a survival OS benefit in stage 3 suboptimally reduced and the stage 4, but in the mature data they have not shown a final survival advantage.
That's exactly.
No, on the contrary, the other way around. In the final analysis, 8 years analysis they have published recently. So in that they have mentioned like it is a 10 months, the OS was 10 months in the heavy burden is stage 4 disease.
That was not significant. I think I don't really remember.
It was significant. It was doubled actually.
Anuj, you are telling something.
Yes, sir. Yes, I want to share one experience of such scenario when the patient was having ascites and pleural effusion. After completion of adjuvant therapy, the patient, the couple was in fact themselves were doctors, and the husband was ophthalmologist. So they were, so he was aware of bevacizumab because he was using in some certain retinal conditions. So and fortunately they were BRCA positive also. So I gave them options of both, about BRCA followed by bevacizumab followed by bevacizumab maintenance, combination maintenance, as well as if they are not willing for bevacizumab, we can also go for olaparib maintenance. So yeah, I have counseled them in the beginning only so that they can decide. So they also had gone through literature themselves also because they were doctors. So they opted for bevacizumab. And later when the disease progressed after certain time, because it was BRCA positive, olaparib I have started. So the patient is doing well on olaparib. So that is experience with one patient. Another patient who was initially treated with this chemotherapy only, and after BRCA, she was also BRCA mutated, and I have started olaparib for that patient. But she had very poor tolerance with olaparib. So her initially experience with olaparib has been mixed type for me. Olaparib, as it causes anemia, gastric discomfort is too much. So I am more comfortable with using bevacizumab, as Asim sir has also already told, because it is have less of a side effect. But again, we have to choose population patient wisely, and we don't know who will benefit of them, because again, it is what we give is a median PFS. So
yeah, understand. Thank you very much, Kaushal. So are you comfortable in handling the side effects when you give bevacizumab and olaparib combination? Have you ever used it?
Yeah, I have used in a couple of the patients, and in clinical practice, it's not much troublesome while using the combination therapy. Fortunately, my all patients have tolerated the drugs combination very well. Beva, we have to take care of the proteinuria and hypertension. So while olaparib has been associated with some of the GI side effects, but with the full dose of the olaparib, they are tolerating the drugs very well now. So fortunately, I do have very good experience with the side effects and tolerance.
This patient is BRCA positive, right? So I'll just come to that discussion, but at this point of time, she had a very tricky question to me. I want every panelist to offer me an answer for this. So I did a mammogram as a standard procedure prior to doing that. So she wanted bilateral mastectomy to be done because BRCA is positive. How many times we have met otherwise? So for breast cancer, we offer oophorectomies. But for this ovarian cancer, how to address the breast? And she was very insisting upon getting her breast removed. She told that, anyhow, Paplicarp we are giving, if it is there, it is going to cure that part of it also. So how many of you really feel that we don't have any data? I completely agree. I just want your opinions on these things, openly and honestly, in a logical manner. I mean, if you are in my condition, what is your counsel to the patient?
Yeah, I will go for the mastectomy.
You advise for the mastectomy. Any difference in opinion?
No,
because Paplicarp is not 100% secure to prevent the breast malignancy, because the BRCA.
I mean, this is what I'm not telling from my side. I mean, she herself, I can't name her profession, but she belongs to one of our communities.
She is good. She is
right.
She has taken good decision actually, in fact.
Yeah.
And I personally advise for the mastectomy, no doubt for that.
Right. So Asim sir, you are having different opinion probably, yeah.
Yeah, Dr. Suresh, I have also two patients, and one patient is BRCA1 and BRCA2 both positive.
Right.
And she has a very strong family history, and she herself is a teacher. So she was insisting, I want to go for the bilateral mastectomy. And the problem is
bilateral, see, ovary to mastectomy, right? Is the same scenario you face.
No, it's not very same, but it is like bilateral mastectomy patient is demanding.
Okay.
And she was nulliparous, so the position was very troubling. But she was insisting, and she was saying like, I will adopt my sister's son. So we said like, go ahead if you want to do it, and by science you need to do it, and the ovarian part also you need to remove. The complete THBSO and ometectomy you need to do, and you do the bilateral mastectomy. So she went ahead and did that. And one other patient also, she was very impressed with the Western data and the celebrities' behavior. So she also went ahead for this bilateral mastectomy. So time has come, like patient herself, they will ask for, and we should advise, or we need to advise the science. And nowadays, I don't know how the internet is taking up. So they are telling some cosmetic solutions also.
Correct.
So they are very much interested, like, no, we will take care of our body image. So you just advise the good doctor to go for this bilateral mastectomy. So we are advising that.
Abhishek, do you
At
see
least we are giving the option.
So,
Thank you.
In my practice, sir, we need to discuss with the patient actually and counsel the patient regarding whatever the options they have. And if at all they are agreeing to the bilateral mastectomy, we do give the option of that.
Will you give an offer for an ovarian cancer patient BRCA positive for a mastectomy, or you just let them speak about it?
So we have to give all the options to the patient regarding regular screening programs and benefits of bilateral mastectomy, and let the patient decide. And we also give the data whether how much benefit is of bilateral mastectomy. And if the patient is willing for the bilateral mastectomy, then we go ahead with that surgery. Although we have not come across such patient till now.
So Anuj, will you feel that BRCA alone is enough, or you want any further testings before deciding on bilateral mastectomy in these cases?
Data has shown that BRCA itself is one of the factors. So to counsel the patient, I think that is enough if you want to counsel the patient. I have counseled a few of the patient, but none of the patient has shown interest for such a radical preventive surgery.
Understandable, completely understandable. Here the patient, after completion of therapy, underwent a bilateral mastectomy. To my surprise, that is her decision. She is very senior to us. So anyway, next slide, please. Next slide, please. Can you, thank you very much. So this is what happened in Germany. I just could pull this slide from CCO. So from 2001 to 2016, it has completely changed. So starting from the non-platinum standard of care to the platinum with new additional bevacizumab and other things coming. Next slide, please. So paclitaxel alone, as most of our panelists feel, is out. You need to give at least bevacizumab because it is cost effective, it is freely available, and it is very well tolerable. And based upon HRD testing or BRCA testing, then you can choose your PARP inhibitor, right? So probably we reach to that consensus of management on the frontline advanced ovarian cancer management. Next, please. So question is, in advanced ovarian cancer, have anyone practiced dose-dense paclitaxel and fractionated paclitaxel? I'm talking about very old trials here. Any experience on these things?
No.
No, we haven't practiced, right?
Yeah,
So,
we don't have interest in this. You may see like ovarian cancer patient, they are tolerating 3-weekly regimen is also in initial 1 or 2 cycle. They have great difficulties in full dose.
Right.
So those days is little bit
out of question for
what to
us.
think about. Yeah.
Yeah, absolutely. Just because there is a literature, I just want to take the opinion on what we have to practice or what we are doing in India, right? Point well taken. Next, please. Next, please. Can I have the next slide, please? Intraperitoneal versus intravenous. Probably that is the next slide. I think, yes, right. Intraperitoneal versus intravenous. How many of you are comfortable with such a big peritoneal disease? HIPEC plus or minus. I mean, one of the speakers spoken very clearly about HIPEC and its evidence. But what is the opinion of this panel on the HIPEC, intraperitoneal versus intravenous?
Yeah, so in era of 2022, where we have availability of the PARP inhibitors, HRD, and all the things, where the role of the HIPEC as well as the intraperitoneal chemotherapy is the questionable.
Correct.
Personally, if we are giving with HRD positivity and giving olaparib plus bevacizumab, I think there is no any role of the HIPEC or intraperitoneal chemotherapy.
Assuming that she is BRCA negative, okay, and she had contraindications for the bevacizumab. I'm just, we are in a panel.
Yeah,
I'm so sorry.
Yeah, I agree. Because sometimes, or even many times, we are facing such type of the patients where they are not affordable for the beva as well as the olaparib.
Right.
So in that particular subset also, I would like to finish with the required dosage of the paclitaxel and carboplatin without any HIPEC as well as intraperitoneal chemotherapy.
Any difference in the opinion from the panelists?
No. The standard, I would like to go with the IV chemotherapy, not intraperitoneal, not HIPEC, and no other fancy thing.
Absolutely. Well, point well taken. Next slide, please. I mean, So I hope Abhishek and Anuj, you agree with the same thing, right?
Yes,
Yes, we
absolutely.
completely
The
agree.
data speaks slightly different, that it is IP is slightly better, but I completely agree with Kaushal that with the era of advanced medications and targeted therapies, I don't think IP is going to have any role. 2006, when we are just coming into the practice, is not same as today when we have multiple drugs in our armamentarium. Next, please.
In that era also, I think only 40 or 50% of the patients completed 6 cycle of intended course of therapy intraperitoneal, and the toxicity was very high.
Right. So just now, Dr. Rajat gave a very important thing. So 50 months in excess. Rajat, sir, I would like to say that all the patients chosen for the IP are very fit patients. There is always a selection bias in that trial. That was the editorial that followed the same thing. But I don't deny the science. The science says that it gave 50 months of survival, which is hardly seen. But in our practice, I hardly was able to replicate the 50 months survival in the IP. They have a lot of adhesions, lot of post-operative complications. HIPEC was initially practiced between 2010 and 14 in my institute and had very bad, I can say, experience or tough time in handling the post-operative period of these patients. Especially bevacizumab, I couldn't give because of obstruction. I always have the fear that it perforates at any point of time. I just would like to see the comments of the others also. Rajat sir, your comments, please. Because
No,
you
I
brought
agree.
it.
So, yeah, but the thing is that it still is a robust evidence. The clinical evidence or the scientific evidence for intraperitoneal chemotherapy with GOG 172 cannot be really, swept under the carpet. 50 months, in excess of 15 months overall survival was quite good, despite 40% patients actually not able to complete the intended therapy. So I think I still would reserve intraperitoneal chemotherapy for the fittest of the patients, explaining to them that is not something which is in vogue, but then this is something which is there. Fittest of the patients, probably yes. And I think we as oncologists would like to probably believe that we also want our quality of life to be good. That is why intraperitoneal chemotherapy we don't want to do.
That's exactly what I told you. 10
This is-
to 14 was a nightmare for me. So every time I get a pain abdomen, constipation, uncontrolled vomiting, NBM, managing the overnight, send it
So
to
we
ER,
we have to
not
agree
very
with
comfortable.
that. We have to agree with that. Yes.
Yeah, absolutely. So
Yeah.
Abhishek and Kaushal, any comments on that? You didn't experience any bad things with it. You never
Use the
practiced.
IP therapy yet, sir.
Yeah, okay. You are fortunate not to see IP in your distinct practice.
Yes, sir.
Right. Yeah.
I think Mito 7 we are talking about. Mito 7 we all of us have used. We get patients who are not having a very good performance status, and we do fractionate our paclitaxel and at times carboplatin as well. So there is a phase 2 study of weekly paclicar with bevacizumab. So Mito 7 also being a phase 3 study, we've done that. Mito 7, I'm sure most of our panelists will agree.
Weekly paclicar, I completely agree that we did use it, but the doses which they recommend, we always give 75% of the dose, Rajat. I don't classically call it as a dose dense as per its spirit. I mean, we followed weekly, but we trimmed the doses significantly. I do still practice on unfit patients. Anywhere between, I just flat the paclitaxel dose to around 100 to 120 based upon BSA, and then flat the dose of carboplatin to maybe 100 to 150. Asim sir, you want to have a comment? Please.
Yeah. So weekly paclicarbo we also give, but we give in the very frail patient who was tolerance is doubtful, and to just build up the patient and not to load with the 3 weekly dose. So after 1 or 2 or 3 weeks, once their PFS you can see like performance test increase, and they are able to take food and all that, their albumin level goes up. Then we start 3 weekly. So it's kind of bridge between the low performance status to the good performance status, and they convert into the 3 weekly schedule so that the less visit required. And for this intraperitoneal chemotherapy, I did in DM from Tata. So there was a trial, institutional trial was running by Dr. Amita Maheshwari. So she could also enroll only 10 patients. see the large volume of the patient we had there, and only 10 patients could be involved in that institutional pilot study. So the conclusion was it was difficult to tolerate. Most of the time patient have intolerable vomiting, sometimes neutropenia, sometimes they have hypotension also. So the life of the residents and the consultants were very difficult. So they dropped the plan to give this. And nowadays the scene is, even if patient request, they used to counsel, or we used to counsel the patient in other way around, like we have the other better option to give you this almost same survival. So it's just I guess it is not practiced all over the country.
Points well taken. So that's what we do jugards out of, we do customize. Yeah. That's a better word to use. So in terms of weekly therapies, we take the best of all the clinical trials knowledge and then adopt to the Indian scenarios. So before we wind up, I think I can see the time is running out because of small technical group. One comment: germline versus sporadic, BRCA versus non-BRCA mutations. What is your take? All, if at all is not affordable, in order of priority, 1, 2, 3, 4. Panelists, please.
Yeah, I would like to go with the HRD and germline BRCA testing if the patient is affordable for that. That's the basic, which will cover everything. If the patient is not affordable for the HRD, then at least for the germline BRCA mutations and somatic BRCA mutation. If he is still not affordable, then at least for the germline BRCA mutation.
Got the order very
clear.
So
I would request you to conclude the panel discussion.
Yes, that is the last question.
So nowadays HRD is free from AstraZeneca, the company, and germline BRCA is on concessional rate. So my take is HRD testing and germline BRCA testing.
Wonderful. Abhishek, your last one.
Absolutely agree, sir. I think we have to do the HRD testing and upfront, and if the patient is not affording, or maybe coupon is not there, so we can give the option of germline BRCA mutation.
Wonderful. Thank you very much. So you can stop the slides, please. Thank you very much. Okay. So to conclude, number 1, 2, 3, 4 should be offered whenever it is offerable. Number 2, Paclitaxel with bevacizumab based upon the BRCA, if it is feasible, add any PARP inhibitors. Number 3, if at all you can't do anything, do at least the germline BRCA. Number 4, whenever it is possible, whenever it is feasible, you can always explore the old science of weekly chemotherapy and intraperitoneal chemotherapy, though most of us cannot follow in its true sense. So with these things, I sincerely thank the organizers for giving the opportunity. Any last comments or questions to be answered by our panelists? We are open for that. Nothing. Thank you very much. Thanks, everyone.
Thank you. Thank you, everyone. Thank you, Dr. Suresh, sir. Thank you, Dr. Aseem Samar. Thank you, Dr. Abhishek, Dr. Anuj, Dr. Kaushal Patel for being with us and sharing your thoughts on this very important topic. Dr. Suresh has really brought out very important points about the role of bevacizumab, role of PARP inhibitors in the management of ovarian cancer. And we do understand that in the era of precision oncology, these are tailor-made therapies that we have for our patients. And all this discussion will help us to really guide our patients as to how to go about dealing with ovarian cancer. Thank you so much once again. So after this insightful panel discussion, we go on to the last session of the topic, which happens to be on the role of TDM1, which is Ujvira. Where does it stand in 2022? This session is sponsored by Zydus, and to take us through the role of Ujvira, we have with us Dr. Manish Sharma, who's a consultant medical oncologist at Rajiv Gandhi Cancer Institute in Delhi. Dr. Manish, good evening. Over to you.
Good evening, Dr. Rajat. Thank you so much. And I was listening to this wonderful discussion. So, Dr. Suresh, one question. So, you have a BRCA mutant patient, and she's in stage 3C or stage 4 ovarian cancer, where you do not expect 5-year survival of more than 20-30%. So, will you offer bilateral mastectomy for these patients? So, I was just wondering whether they should be offered bilateral mastectomy when you are expecting a 4-year, 5-year survival of 20-30% in these patients?
That is because the patient doesn't want to have any mortality with breast cancer.
So, so Dr. Rajat, see, if you are having such a low 5-year survival with this disease, and if you talk about progression-free survival, so it is even lesser. While offering a bilateral mastectomy, I don't know if it makes sense or not.
No. So I'm telling you the patient's psyche. I understand with you, but the patient wanted that because of that reason.
So thank you so much and for inviting me here, and I congratulate you for organizing this year and this conference. And I will be speaking on Ujvira and where does it stand in 2022. I know most of us are now tired and waiting for lunch and for dinner. So this is what we are going to discuss. We are going to discuss about HER2 targeted therapies, TDM1. TDM1 in early breast cancer, the role in metastatic breast cancer, and what are the conclusions. So I will try to finish it in 15 minutes, which have been allotted to me. So these are HER2 new targeted therapies which we have in our armamentarium. So some of them act inside the cell membrane in the inner domain, and some of them act on the outside the cell membrane, that is the outer domain. So trastuzumab, pertuzumab, margetuximab, TDM1, TDXT, they act in the outer domain. While the TKI are also available, such as lapatinib, neratinib, and tucatinib. So here is the antibody drug conjugate TDM1, which we are going to discuss today. So what is TDM1? Basically, it is an antibody drug conjugate where the trastuzumab has been linked with the help of thioethyl to the DM1. So DM1 is a cytotoxic material. It is linked to the trastuzumab, and 3 to 3.6 DM1 moieties are present per trastuzumab molecule in this TDM1. So what is the mechanism of action? The mechanism of action seems to be very, very simple, but it is a very difficult drug to manufacture, and I congratulate Zydus for doing so. So once you have a TDM1, it attaches to the HER2 receptor as the trastuzumab would do. This drug is an endocytosis. With the help of endocytosis, the drug goes inside. The thioethyl is now unlinked, and the DM1 is released. So this DM1, it is a microtubule inhibitor which leads to the apoptosis of the said cell. So this is basically a targeted. The TDM1 is approved in 2021 for the following indications. So it is approved for the adjuvant treatment in early breast cancer for those patients who have received neoadjuvant taxane and trastuzumab, and they still have residual disease. It is also approved in the metastatic breast cancer in second-line or third-line setting for those patients who have received taxanes and trastuzumab. So these are the two clinical trials, Catherine and Attempt, for TDM1 in early breast cancer. So TDM1 basically in the Catherine trial attempted to reduce the invasive disease recurrence in those patients who had some residual disease. While in Attempt trial, it was attempted to see whether we can offer the patients chemotherapy-free regimen, that is the treatment which does not have chemotherapeutic arm. So this is the Catherine trial, and here the early breast cancer patients from stage T1 to 4 and node 0 to node 3 who had some kind of residual disease in breast or axillary nodes post neoadjuvant chemotherapy plus HER2 new targeted therapy. So these were the patients who were offered TDM1 for a total of 14 cycles, oblique trastuzumab, which is the standard of care. So these are the patients who did not achieve YPT0 and 0. The primary endpoint was invasive disease-free survival, and the secondary endpoint was the distant recurrence-free survival, overall survival, and the safety analysis. So this is the Kaplan-Meier curve for invasive disease-free survival, and you can clearly see here that there is a 11% difference in 3-year invasive disease-free survival, which was 88% in TDM1 arm versus 77% in the trastuzumab arm. And the hazard ratio is also significant. There is 50% reduction in the risk of recurrence in this Catherine trial for those patients who had received TDM1. So this was in the favor of TDM1. So many times I have seen in discussions, there is a question whether those patients who had received pertuzumab and trastuzumab as a new adjuvant chemotherapy should be receiving TDM1 or not as per Catherine trial. So please see here that in Catherine trial, there were 18% of the patients who received pertuzumab and trastuzumab, both of the targeted therapies. And you can see here whether the patient has received trastuzumab or whether the patient has received pertuzumab plus trastuzumab, there is an incremental benefit. So there is an incremental benefit of 11% in those patients who have just received trastuzumab. And even if the patient has received pertuzumab and trastuzumab and has some residual disease, even in that case, there is 10.5% of the incremental benefit in 3-year invasive disease-free survival. So adjuvant TDM1, it builds on the efficacy gain with the pertuzumab and trastuzumab in neoadjuvant. So there was not even a single subset in which the TDM1 did not work, and you can see here, irrespective of age or hormonal status or preoperative HER2-directed treatment, the TDM1 arm was better as compared to the trastuzumab. These are the secondary endpoints which were still significant. This was phase 2 attempt study, TDM1 versus taxane plus trastuzumab followed by trastuzumab. So here the specific subset was asked for, and it was just stage 1 HER2 positive breast cancer who did not have any kind of nodal disease burden. And we know that for these patients, the standard of care is to offer 12 cycles of paclitaxel plus trastuzumab followed by maintenance trastuzumab, and this was compared against TDM1 of total of 17 cycles. So if you see here, the curves, they are exactly matching. So 3-year DFS in both the arm was exactly the same. It was 97.7% versus 96.2%, and p-value was not statistically significant. So this is DFS with TH. And if you see the side effects, so number of side effects and the events was lesser in TDM1 arm as compared to the chemotherapeutic arm. So I don't say that in early stage disease you should give TDM1, but yes, this is one of the options for those patients who have contraindications to paclitaxel. So those who are very severe neuropathy, or they are reluctant that they should not be having any kind of hair fall, or if you are if the patient is afraid of infusion, yes, this is one of the options, but still not standard of care. So this is 2022 adjuvant systemic treatment after preoperative neoadjuvant chemotherapy. And if the patient is HER2 positive or hormone receptor positive, in both the cases, if there is a residual disease, the trastuzumab emtansine, that is TDM1, is category 1 indication, total of 14 cycles. And if the patient is hormone receptor positive, you have to add endocrine treatment along with the TDM1 for these patients. So this is the strategy for managing patients in stage 1 to 3 hormone receptor positive patients. Those patients who are less than 2 centimeters of the disease, that is clinically stage T1 and node negative, they can be taken up for surgery followed by chemotherapy and total of 1 year of hormone trastuzumab treatment. But anything which is more than T1C, these patients should be offered TCHP or AC followed by THP. If they have residual disease, TDM1 is the answer, and if it is YPT0 or M0, just giving trastuzumab is an option, but pertuzumab is even added if initially the nodal burden was low. So talking about TDM1 in HER2 positive metastatic breast cancer. So the data comes from these 3-4 different trials, and this is Amelia trial, Theresa trial, Camellia, which is one of the subset of the Amelia trial, Marian trial, and some of the real world studies. So we'll be discussing about them one by one. So from all these studies, if you see the evolution of TDM1, so Amelia, Theresa trial, Camellia, Marian trial, almost more than 5,500 patients they have been on this treatment, and there is a very comprehensive clinical trial experience. So after first line trastuzumab based therapy, TDM1 provides superior efficacy related to the other HER2 positive breast cancer treatments such as lapatinib or capecitabine or beyond or the treatment of the patient's physician choice. So in the Amelia trial, the lapatinib plus capecitabine, which was the standard of care in the second line HER2 positive breast cancer, it was compared against TDM1 for those patients who had prior taxane or trastuzumab. And similarly, in Theresa trial, the TDM1 was given in the third line setting. So third line setting as against the treatment of patient choice. Those patients who had more than equal to 2 prior HER2 directed. So these are the results from the Amelia study, second line study. If you see here, the median progression-free survival was 6.4 months versus 9.6 months for trastuzumab and tensinomab. Well, if you see overall survival, you have approximately 6 months benefit. So 3 months benefit in progression-free survival and 6 months benefit in overall survival. If we talk about Theresa trial, you can see the similar kind of results here. This is beyond second line. So the treatment, so TDM1 in third line comes from the Theresa trial. And you can clearly see here that median PFS for physician's choice was 3.3 and for TDM1 was 6.2. So almost double the PFS here. And if you see about median overall survival is 7 months better. So 3 months benefit in progression-free survival and 7 months benefit in overall survival. So you please see here that 30% of the patients, they had more than 5 lines of treatment. So it is such an effective drug. Even if the patients had 3 or 4 or 5 lines of treatment, there is overall survival of more than 7 months advantage. So this is the Camellia study, one of the study which clearly shows that the patients who had baseline CNS metastasis, they also benefit from TDM1. So there was a concept that only lapatinib and capecitabine would cross the blood-brain barrier and help these patients. But the data is clear from Camellia and the post-hoc analysis of the Amelia trial that those patients who had CNS metastasis, they have some degree of response and overall survival, which can be to the tune of 40%. So you can see that the clinical benefit rate for those patients who had brain metastasis in TDM1 arm was around 40%. So this is the Marian trial, and the question here was whether the TDM1 can be used for the patients in the first line setting. So this was phase 3 study of TDM1 plus minus pertuzumab versus trastuzumab plus taxane. And these patients, the primary patients were those who did not have any kind of chemotherapy in a locally advanced breast cancer setting or metastatic breast cancer setting. The patients, they received TDM1 plus placebo, TDM1 plus pertuzumab, and trastuzumab plus docetaxel or paclitaxel, which is the standard of care. Sorry. So you can see here that the PFS and overall survival, it was exactly the same for all of these. So the investigator concluded that the result supports that TDM1 as a first-line treatment for patients with HER2 positive breast cancer can be used for those who are not suitable for taxane-based treatment. So similar kind of results, they were also seen in the Attempt trial, which we had discussed. So this is the strategy for managing patients with HER2 positive metastatic breast cancer. Patients, they receive pertuzumab, trastuzumab plus taxane-based treatment, followed by maintenance of pertuzumab and trastuzumab. On the failure, they can receive TDM1/TDXT if it is available, although TDXT is not currently available. And then this can be followed up by tucatinib plus trastuzumab plus capecitabine, trastuzumab, docetaxel, or vinorelbine, and plethora of choices are there. Niratinib is not available, margetuximab is not available. So this is a flow chart of the patients of metastatic breast cancer who have HER2 positive breast cancer. So this is the data from the Indian study in TDM1. It was published in ASCO June 22. Dr. Ajay Gogia was the lead author in this, and 80 patients were there, de novo, 47% patients were de novo, and advanced breast cancer patient, prior history of LABC or EBC, the metastatic disease, lung, brain, liver, bone, lymph node. The response rates, complete responses in 10% patient, partial responses 45% patient, and stable disease was seen in 15% patient. Progression-free survival 10 months and overall survival 27 months for these in the Indian patients. So there was a large unmet need for TDM1 because we know the product from Roche was extremely costly, and not more than 5 to 10% of our patients would receive this drug despite having so much of clinical advantage. And this unmet need was met when the Zydus came up with Ujvira, and the Zydus has presented the efficacy, safety, and pharmacokinetic and immunogenicity data of Ujvira as compared to the Kadcyla, and this was published in Clinical Breast Cancer Journal. The efficacy, overall response rate at 24 weeks, safety, pharmacokinetics for 50%, and antibody data, it was presented in this clinical paper in 168 patients. So in conclusion, the results demonstrated that the biosimilarity between Ujvira and Kadcyla in patients with HER2 positive breast cancer with respect to efficacy, safety, pharmacokinetics, and immunogenicity was exactly the same. And hence, Ujvira is one of the drugs which has come up, and we now have met the need which was earlier unmet for these breast cancer patients. Thank you so much for patient listening.
Thank you, Dr. Manish, for taking us through the nitty-gritties of this ADC, which has actually been a game changer in breast cancer, be it the metastatic or the early breast cancer setting. What has your experience been? Any untoward side effect you've seen with TDM1 in the patients that you've used TDM1 in?
So I think, Dr. Ajit, most commonly which we encounter is fatigue, transaminitis, and thrombocytopenia. So thrombocytopenia is sometimes a challenge. So after receiving some 8 or 9 cycles, I frequently encounter thrombocytopenia.
And about 5% of the patients in both the trials had unexplained bleeding. Any patient where you experienced bleeding?
So I have seen this discussion in various clinical forum that patient had bleeding, but touch wood, none of my patients had bleeding from this.
Okay, nice. The other thing is that there is a little worrying thing about Cadrine, where it was seen that in patients who were given TDM1 versus patients who were given trastuzumab based maintenance, there were more number of first CNS relapse in the metastasis when it happened in TDM1 arm as compared to trastuzumab arm. That is, the first site of relapse was more of brain in TDM1 as compared to trastuzumab. So we have learned over the years, according to the Amelia study or the Camilla study, that TDM1 works better in brain as compared to trastuzumab. So what is your take on it? What could be the reason for patients failing in brain more in TDM1 arm as compared to trastuzumab?
I think this is somewhat controversial. I don't know why it has happened, but from this Camellia and the exploratory analysis, we have seen that there are the responses which are in tune of 25 to 40%. So, what is your thought on that?
So one of the explanation which was given by the PI was that since the patients have been living more with TDM1, so probably this is a error of judgment that there are more CNS metastases in TDM1 group. So that could be one of the reasons. But then we would come to know about this more once we have the overall survival data of Catherine study. This was one of the postulated theories that the PI put forward. Although the incidences, they were just numerically higher and they were not statistically compared. It was about 5.5% versus 4.2%. So not statistically compared. They may not be statistically significant also. So yeah, and the last thing is that with the coming in of Destiny Breast 03, do you think that there will be time when TDM1 will no more be preferred once TDX comes into Indian market next year?
So I think it's a very price sensitive market which we have here. TDXT would be, I think, would be much more unaffordable for most of our patients as was TDM1 was. Not more than 4-5%, 10% patient would be able to afford that. For that matter, TDM1 is my TDXT for now.
Okay, but then with TDX coming in, and if the patient is affording, would you like to use TDX over TDM1?
Yes. So we have to go by science, and TDXT definitely is.
Okay, right. Thank you so much for taking us through this important topic of TDM1 in breast cancer. With this, we come to the end of this day one of this current oncology update series, where we talked about the gynecological malignancies and their updates starting from endometrial cancer to ovarian to breast cancer. I thank you all for being a part of this discussion since evening, and I think we take home a lot of important things about the new updates which have come and how to really incorporate that in our clinical practice. Tomorrow being day 2, where we're going to talk about the lung cancer updates and their management. We would like to have your presence there at 6:30 p.m. tomorrow. So until then, wish you a great evening from my side, and thank you very much. Good evening.
Thank you everyone for joining. Good night and meet you